Good afternoon, everybody. I'm Fran Ehrenberg, one of the pediatric cardiologists from Cleveland Clinic, and I'd like to welcome you, those in person here, as well as those online, to our echo and imaging breakout session. My co-moderators, Dr. Malik Yaman from Cleveland Clinic and Dr. Jennifer Kovu from Florida. We have a couple, just for housekeeping things, a couple of changes or slight changes in our agenda. Dr. Meryl Cohn will be presenting first, and Dr. Nick Suji was unable to join us due to some urgent family issues, so I'll be speaking in his stead. And because Dr. Cohn is joining us, from her home, we'll have a few questions if there are any for her sessions, but then afterwards we will hold all the other questions until the end, and we'll have a panel discussion at the conclusion for any questions. So I think I'll turn it over to Dr. Kovu to introduce Dr. Cohen.
Well, Dr. Meryl Cohen needs no introduction. She's one of the amazing cardiologists from CHOP, and today she's going to be talking about unbalanced AV canal. Meryl?
Can you guys hear me?
Yes.
Yes.
Okay, sorry, I didn't know I was going first, so wasn't really ready for that, but I can be, so just give me a second. Can you see my slides?
Yes.
All right, awesome. All right, thank you all for inviting me to this really interesting session on parts with significant challenges to septation. I think this is always a fascinating topic, and obviously there's going to be a variety of lesions that can be discussed, but I'm here to talk to you about unbalanced AV canal. And so how do we define unbalanced AV canal? It's when the AV valve is aligned more over one ventricle than the other, and that typically is associated with hypoplasia of the contralateral ventricle. And unbalanced to the right is much more common than unbalanced to the left. And for the rest of this talk, I will be talking about the right dominant form, where the right ventricle is the large ventricle, because though left dominant form is important too, there's less data on that, and the strategies tend to be a little bit different. And so we'll also highlight that when you have unbalanced AV canal, the left ventricular outflow tract is vulnerable to obstruction, and I'll come back to that several times in the talk. And despite our best efforts in treating this lesion, there remains a high morbidity and mortality. And so with regard to the left ventricular outflow tract, why is it vulnerable? These are some beautiful specimens from Diane Spicer, where she's cut away the atrium and looking down at the base of the heart. In the normal heart, you can see two clear annuli of the tricuspid and mitral valve, with the aortic valve wedged between them. When you have a common AV canal, you have a common annulus or junction, whichever you choose to call it, and that leads to the aorta being more anterior in the heart. And that more anterior aorta elongates the left ventricular outflow tract and gives it what we call that gooseneck deformity, which we see on echocardiography as well as on angiogram. It makes the outflow of the LV longer than the inflow. In the normal heart, those two measurements are very similar. And this elongation is seen in all types of AV canal defect. And so LVOT obstruction is common because the left ventricular outflow tract is smaller and longer than normal. And often there are other things too, like AV valve tissue in the way. Left ventricular hypoplasia overall has a continuous spectrum of disease, from mitral and aortic atresia, where the left ventricle is essentially not formed, to total anomalous pulmonary venous connection, where the left ventricle is compressed by the right ventricle because of the physiology, but in a group of patients who we would essentially always do a two-ventricle repair. And so in this spectrum, we're trying to determine a really dichotomous treatment option, either single ventricle palliation or two ventricle palliation. And sometimes this can be quite challenging. More recently, strategies have been developed to stage patients towards two ventricle repair, and I'll show some examples about that at the end. So with regard to single ventricle strategy for right dominant unbalanced AV canal, it's considered to be a higher risk lesion than so-called straightforward HLHS and stage reconstruction. And we really try to steer away from single ventricle palliation and Down syndrome cohort because they're at higher risk for pulmonary vascular disease and things like that. And a common theme is that AV valve regurgitation in AV canal is very common and is common if you go down the single ventricle pathway, and I'll show you that in a moment. But the two ventricle strategy is not perfect either for this cohort of patients. It's very difficult to predict severity of unbalance. And when we close the AV septal defect, it is very hard for us to determine if we have enough left ventricle, enough left AV valve, enough outflow to provide adequate cardiac output. We talked about the left ventricular outflow tract obstruction. And then because the left side of the common AV valve is trifoliate, and the superior and inferior bridging leaflets, which form the so-called cleft, are the primary commissure because we worry that we can't close the cleft in this situation because we might cause stenosis. These patients are vulnerable to left AV valve regurgitation. And so all of these components, the left side being a little bit too small, the LV outflow tract obstruction, left AV valve stenosis and or regurgitation, put these patients at significant risk for pulmonary hypertension. If you look at patients who have had single ventricle in association with AV canal defect, the cumulative survival at 20 years is about 68%, similar to studies that we see in other forms of HLHS. But those with moderate to severe AV valve regurgitation, which you see here in green, do far worse than the others. And freedom from AV valve reoperation in this cohort of patients is only 47%, so more than half need reoperation. If you then look at the cohort of patients who undergo single ventricle reconstruction to Fontan over a very long period of time, and this is a beautiful study done out of Australia, you can see that common AV valve regurgitation in blue is more likely to need AV valve surgery than a mitral or a tricuspid valve. And those with valve failure, seen here in red on the right, have worse transplant-free survival than those without valve failure. So single ventricle palliation in this setting is not ideal. So why haven't we figured all of this out? Well, the pre and post-operative physiology are quite different. The two surgical strategies that we use to treat this disorder have different risk factors for failure. An intervention may leave residual hemodynamic abnormalities, including AV valve regurgitation, stenosis, residual defects, and even give you something like shunt thrombosis if you go down the single ventricle pathway, which has absolutely nothing to do with the anatomic details of the underlying lesion. In contrast to other forms of LV hypoplasia like critical aortic stenosis or arch hypoplasia, unbalanced AV canal has many variables to consider, including the AV septal defect itself, the left ventricular outflow tract, as I keep harping on, and the common AV valve. And so we're trying to predict that doing this kind of a septation or plane in space is going to wind up with a left ventricle that is able to eject enough cardiac output to the body. And that's where our dilemma lies. So how do we define unbalance? There are several ways that it can be done, but one of the ones that we've come up with in my own institution is the AV valve index. And what this is sort of apportioning the part of the valve that sits over the right ventricle and over the left ventricle. And in this initial, the first time we did this, we did it in a ratio of right over left. And this was a paper, the very first paper I wrote as a cardiology fellow. And our conclusion from this paper was that echo morphometry is useful in defining unbalance. And if that ratio of right over left AV valve was less than 0.67 in the presence of a large VSD, then a single ventricle approach was recommended at that time.
Meryl, could I interrupt you for 1 second? Could we ask you to hit the thing that says use slideshow at the upper left of your screen?
Oh, is it not working?
Yes, perfect. That's great. Thank you.
Oh, I'm so sorry. What, it wasn't working?
No, we saw your slides. They just weren't in the slideshow mode, so it wasn't as big, but now we can see everything great.
I
Thank
see.
you, and
Okay.
sorry to interrupt.
No, not at all. My apologies for that. Since then, we have modified the AV valve index through the Congenital Heart Surgeon Society, which did a large multi-institutional cohort study. And we determined that really the ratio was better if we did the left AV valve over the total AV valve. It led to less enhancement of the extremes. And so we determined that we decided actually that a AVVI less than 0.4 was the right dominant form of the disease, more than 0.6 was left dominant form, and in between 0.4, 0.6 was balanced. And so we were able to apply a frequency plot of AVVI by surgical strategy. We were blinded to the surgical strategy, so we didn't know the outcome of the patients. And you can see that AVVI fares pretty decently with regard to surgical strategy. Those patients who had an AVVI of 0 to 0.2 overwhelmingly underwent a univentricular repair. And those who had an AVVI between 0.4 and 0.6, which we deemed balanced, overwhelmingly underwent a biventricular repair. And then there was this area of heterogeneity between 0.2 and 0.4 where people underwent both types of repair. And there were also a cluster of deaths within this group of patients. And so this was the area where patients seemed to be the most vulnerable in the decision making. We had 7% mortality for the biventricular repair group and 22% for the univentricular repair group. And we also did a prediction nomogram depicting the probability of a given surgical strategy by AVVI. And so the majority of patients, again, who had an AVVI less than 0.2 underwent a univentricular repair. The majority of patients who had an AVVI greater than 0.4, a biventricular repair, and there was this 50-50 cross at about 0.2. So AVVI really can predict unbalance and helps predict surgical strategy to some degree. We also associated AVVI less than 0.4 with a variety of other measures of LV hypoplasia, including LV size, aortic valve annulus, VSD shunting right to left, augmenting cardiac output, LVOT obstruction, and arch hypoplasia. But of course, it turns out that AVVI is not enough. Unbalance of the valves may not correlate always with ventricular volumes, and there are other geometric abnormalities that have to be considered and are not accounted for by just that measurement alone. It also doesn't predict AV valve competence, and it's important to recognize that when the LV is somewhat small, it is non-compliant, and these patients often have primarily ASD physiology early in life, which gives them a very high QP, possibly a low QS, and pulmonary systemic PA pressures. So we have to investigate other aspects of LV inflow. And here you can see a valve, which at the level of the AV valve doesn't look terribly unbalanced, but when you look, you can see that the AV valve leaflet entirely covers the LV inflow. And when you play the echo clip of this same patient, you can see that all of the flow from the atria are going into the right ventricle. And the only way blood is getting into the left ventricle in this case is through the VSD. Sorry for that. So we did some further investigation at our institution, looking at how much blood is actually getting into the left ventricle. So we measured the color flow getting into the ventricle divided by the actual left AV valve annulus in a number of patients who had biventricular repair. And this index, this inflow index, did indeed predict survival of two ventricle repair, and no patient who had an index less than 0.5 survived two-ventricle repair. There were, of course, other risk factors for poor outcome, including younger age at surgery, and if the left AV valve, was abnormal, like a parachute or something like that. And then the Congenital Heart Surgeon Society cohort, we sort of did a grab bag approach, looking to identify features that characterize unbalance and its impact on outcome. And we made a variety of measurements and then did a cluster analysis to assess which features distinguish groups of patients, and did a discriminant functional assessment. And what we found was that this measure, the RV to LV inflow angle, if you will, that's what we described it as, really just characterized sort of three different groups of patients who didn't have really that much overlap with this measurement. And you can see that this shallow angle here was associated with the majority of patients undergoing a biventricular repair with pretty good survival, and a more acute angle was associated with less biventricular repair and worse survival, and we really couldn't discriminate outcome based on these two cohorts of patients. But we felt like we were onto something in that this is likely a surrogate of VSD size. The smaller the VSD, the more blood is able to get into the left ventricle. The more acute the angle, the smaller, the less blood is able to get into the left ventricle. And others have looked sort of in a different way at this as well. The group in Argentina, which has done some really nice work, came up with this index VSD, which is very similar to the angle that I just described to you. And that, along with the AVVI that we described, help them clarify surgical decision-making. Smaller defects or smaller indexed VSD were more likely to survive biventricular repair. So really the conclusion we reached in 1996 about the presence of a large VSD being a risk factor has really held over all of these decades. And why does the VSD size matter? Well, a smaller VSD suggests that the LV can support the systemic circulation. The shallower that angle or the smaller that index VSD, the more flow is able to get into the left ventricle. And the opposite applies too. If you have a larger VSD, that suggests that the RV is augmenting the systemic circulation, and this RV to LV angle is more acute with less inflow into the left ventricle. Here you see in an AV canal patient where the majority of flow is getting into the right ventricle, that the blood is getting into the left ventricle through the ventricular septal defect. There's right to left shunting there. What about the left valvar morphology? The mural leaflet tends to be smaller in patients with unbalanced AV canal, and that makes the primary coaptation of the left AV valve between the superior and inferior bridging leaflets, or the so-called cleft. And so there's likely more risk of AV valve regurgitation when you try to septate these patients. Here you can see that the mural leaflet's quite small in this subcostal view and this 3D image. The majority of the valve is superior and inferior bridging leaflets coming together. And you can see that here as well. And so we looked at left valvar morphology with regard to late valve regurgitation and AV canal defect a few years ago. And it turns out, of course, that the mural leaflet is smaller and more acute in those patients who are unbalanced. But we actually found the opposite of what we would have expected, in that there was increased odds ratio of late regurgitation in patients with wider spaced papillary muscles and larger mural leaflets. So sometimes you find things that you don't expect at all. And this really requires, I think, multi-institutional assessment to see if this is really true or if it was just a red herring of some kind. And what about LV volumes? Well, in the late 90s, the group from San Francisco did some assessment of unbalanced AV canal to assess potential LV size. If you septated the heart, that the left ventricle would expand. And there's been some nice work. This paper is referred to all the time with regard to the lowest limit of LV volume in any patient with LV hypoplasia being about 20 mLs per meter squared. And this paper elegantly showed you that echo really underestimated our ability to measure LV end diastolic volume. And so cardiac MRI in these very borderline cases should be considered to measure those volumes. John Foker in the late 90s from Minnesota came up with this idea of a staged biventricular repair, at the time quite novel and still being used today. He recognized the complete repair was associated with high mortality and staged using a closure of the primum ASD with a fenestrated atrial communication in case that the left atrial pressure was high, left the VSD open to augment the cardiac output from the right ventricle to the aorta, and put on a pulmonary artery band to protect the pulmonary vascular bed. So I'm just going to leave you with a few cases just to show you that all of these measurements are not perfect, and it doesn't always turn out the way you think. This was a newborn with what we thought was mildly unbalanced complete AV canal to the right. Her AVVI was about 0.38. That index, the inflow index was 0.67, so good inflow into the left ventricle. The angle was relatively shallow. There was a large primum defect, but there was very clinically important common AV valve regurgitation and a very small but unobstructed left ventricular outflow tract. The arch was diffusely hypoplastic, but there was no coarctation. So here you see that there was significant AV valve regurgitation in this patient. And I think we perhaps underappreciated how small the left ventricular outflow tract was. Aortic valve annulus Z-score was minus 2.5, but also underneath the aortic valve, it was quite small. So what did we do? We did an MRI, which demonstrated that the QP to QS was incredibly high because of poor LV compliance, and the QS was very, very low. So this patient was really at risk of sudden death, and we did not discharge home because of that. And then surgery was performed at 2 weeks of life using that Foker-like approach, primum ASD closure. We did partial valvuloplasties of the left and right AV valve and a pulmonary artery band. But you can see that there was still significant AV valve regurgitation after the surgery. And even though the left ventricular outflow tract did not have a gradient across it, you can see on the pulse Doppler that there was a very short ejection time and the cardiac index was low. And this patient did not survive, unfortunately. Took another patient who came to us a bit later with a 3-month-old with Down syndrome, referred from outside the country, and had an absence of the RSVC with a dilated coronary sinus. The unbalance at the AVVI was 0.38. The LV inflow index was even narrower than the patient I just showed you. It was really quite borderline. Large atrial and ventricular components, but this patient had minimal AV valve regurgitation, which I think turned out to be very important, and no arch obstruction. And so what to do? Well, we didn't want to really do single ventricle strategy for Down syndrome. So we decided that perhaps the right ventricle was significantly dilated because of the atrial level shunt. All of the measures that we made were quite borderline, but there was no arch obstruction, and the left ventricular outflow tract was smaller. So we did the same thing. We closed the atrial communication and put on a pulmonary artery band. And you can see now that this patient has minimal left AV valve regurgitation after the band and the septation of the atrium. And the cardiac index is much improved. And ultimately, this patient went on to a successful complete biventricular repair. And this last case I'll leave you with, again, unbalanced AV canal, AVVI 0.35. The index was very narrow, but this family was very motivated to have a 2-ventricle repair. Look at this left ventricular outflow tract. There's AV valve tissue in the way there, and it's also very, very small. There was no coarctation, however. And because this family was quite motivated, we did the fenestrated ASD patch. We resected the LVOT and put on a loose band. And in the operating room, things looked quite good. There was minimal left AV valve regurgitation, and even in the initial post-op, at least mild regurgitation, but certainly not severe. And the left ventricular outflow tract looked unobstructed, and we were feeling quite good about ourselves. It has to be recognized that this type of fenestrated ASD patch, when the left atrium and the left AV valve are small, is at tremendous tension. And so the patient developed respiratory distress 10 days after the procedure. And you can see here that the patch completely dehissed and sort of flapping in the breeze there. Hopefully you can see that. I'll let it play. You can see the flap there. And the patient developed severe left AV valve regurgitation, which you can see here as well. So ultimately, this patient was taken down to a DKS and a BT shunt. And I think we're still trying to figure out what the next steps are for this patient. So what have I learned in 26 years of assessing patients with an unbalanced AV canal? Well, AVVI is a valid diagnostic echo tool that clearly identifies unbalanced AV canal. There are other helpful surrogate markers of LV adequacy, which I have shown you, including LV inflow index, the angle, and index VSD. But these tools do not account for all variables, and some will fail despite our predictions. And sometimes you have to just take the best of bad options. A stage biventricular repair may be a good alternative for some patients, but it doesn't work in all, and there is still much more to learn. Thank you very much for your time.
Thank you so much, Dr. Cohen. If you can stay for 1 second, and we'll take questions for Dr. Cohen right now, and we'll not wait till the end of the session.
And Dr. Cohen, if you were planning to stay with us for the entire workshop and you want to have all the discussions at the end, we could do that, but we thought to give you the option to tackle questions for your part of your workshop. Whatever works.
However you want to do it is fine with me.
All right. Okay, well, how about we take the questions now from the audience here, and then we'll also look and encourage people to send us questions virtually so we can... So, I mean, I can kick off with a question. So I'm curious to see, have you had enough experience with the staging to recommend it for any patient that you have serious doubts about their ability to tolerate biventricular repair? Like, I know you've shown us a couple cases, but have you had some pretty good success in more than just a few cases to recommend it as a safer strategy to figure out how things are going to turn out?
Yeah, we actually are in the midst of trying to collect that data to figure out, what the outcomes are from that strategy. And I know it's done at other institutions too, like in Boston. I do think that it may be a good alternative strategy for some patients, but what we have found is it really is a matter of the AV valve regurgitation. That's the killer. If you have a lot of AV valve regurgitation afterwards, and in some of these patients, they have deficient AV valve tissue, so there really isn't much in a very small baby that the surgeon can do to fix that without causing significant stenosis, then you're really kind of stuck. So the ones who have significant AV valve regurgitation, which if they have it before the surgery, then they may not be a great candidate for it. If they have minimal regurgitation before the surgery with this type of imbalance, I think that those are the ones that are going to wind up being the best candidates for this. So that's kind of what we've learned along the way.
Do you feel like just if you septate from the atrial side only, does that, provide less stability for the AV valve than if you were to do the complete septation based on that case you showed us where it dehissed?
Yeah, I think the surgeons probably can answer that better, but I do think it is somewhat unstable to attach the, I think it can be quite a bit of tension where you attach the primum repair to the AV valve, and it has the potential to distort the AV valve because you don't have the support underneath of the VSD patch. And so I think that's where we sometimes struggle with this. You're leaving the VSD open to augment cardiac output to the aorta, but perhaps like partial closure of the VSD to give some stability to the AV valve may be a strategy that could be used, and it would be interesting to see what the surgeons think about that or say about that, because I think that might be a better way to try to give some stability to the AV valve, which winds up being a problem. The other issue is the LVOT. It's very hard to predict if the LVOT is going to be okay or not after this surgery. And obviously you can always repair an LVOT later, but it's very hard to do that in these very small babies. And even trying to do a Ross or something like a Ross Cono in AV canal is very challenging. So we face a lot of struggles with this particular lesion.
Great talk, Dr. Cohen. I have one more question. What do you think, does age matter, or does that factor in the success of septation, or it doesn't really matter? And the other thing is Down syndrome babies. You know how anecdotally Down syndrome babies with AV canal do better than non-Downs. Is it also the same in these cohort of patients?
Well, Down syndrome babies tend to have balanced AV canal. They also tend to be Rastelli C, so the surgeon tends to have more flexibility of where they can put the AV valve when they're repairing it. They sort of have a more primitive form of the disease often. So although we haven't really been able to figure out why they do better with AV canal surgery, it's probably related to those anatomic details to some degree. When they have unbalanced AV canal, I think their outcome is not any different than the outcome for non-Downs patients. And I don't know of data, maybe you do, of whether AV valve regurgitation is more prevalent in the Down syndrome population or not. When you look at these big outcome studies, it doesn't seem to pan out that there seems to be much of a difference between the two groups. Then when you ask about doing it later, it's hard to know what you mean by later. I mean, for unbalanced AV canal, we generally, if we're going to do a two-ventricle repair, often will palliate the patient in the newborn period, particularly if their arch is obstructed, and maybe consider putting in on a pulmonary artery band or not. When you put a pulmonary artery band on, then you can unmask LV outflow tract obstruction. So that's something to think about and consider, particularly if they have arch obstruction. So it's very tricky. If we can wait on these patients, we try to. And the ones I think that we can wait longer, that give the time for the left ventricle to grow, particularly if we do that staged approach and let it tend to do a little bit better. But it's such a rare disease and everybody does it a different way, and there isn't a really solid strategy that everybody has used for us to do a really good outcome study on. I don't know what you think, Jen.
I agree with you. I think we also don't have any answers on why the Down syndrome do better. And again, in balance, the unbalanced, it's the same. I agree that it's the same. And I agree with you too. There's only so much leeway where you can wait. And I was just wondering if you tend to, like, if you have a magic formula that if you wait this much more, they will be better. But I guess we're still.
No, I wish we did. And you're also weighing the risk that they develop pulmonary hypertension, right? So you're sort of on this precipice constantly of, when do we go in, and when is it going to be okay, and when can you really repair the valve and not do it? And it really is a completely separate entity from other forms of LV hypoplasia. I think that's really the take-home message. You can't really treat it like the other forms, like critical AS and arch hypoplasia, because of all these other factors. AV valve regurgitation is just really bad, and this is the disease where you see it manifest the most.
Well, thank you very much, Dr. Cohen. Great talk. And do we have another?
Yes, it looks like we have one question from our virtual audience. Let's see. Why did you not want to do single ventricle repair in the trisomy 21? I believe we...
we answered. I mean, the outcome data suggests that they do poorly with that strategy for a number of reasons, but their airways lead them to have high pulmonary vascular resistance, which is a no-no in Fontan. And so they just tend to do very, very poorly with that. I mean, there are a few who have survived, but it's a struggle to get them through.
And I know, Fran, you had a question.
I have one last question, if that's okay.
Sure.
Obviously, it's not an issue for septation, but some people make much about the unbalance at the atrial level of the atrial septum, sort of creating a double outlet of the one atrium or the other. Do you think that that has sort of implications, or does it sort of stratify patients in some way that, has something to do with their ultimate kind of outcome and success of their surgery, or not too much?
I haven't found that to be a major issue, just because I think that is something the surgeon can treat pretty easily. It may be a marker of things, just to begin with, but I think the surgeons can generally septate the atrium pretty easily, and cut that part out if it's causing impingement on one side or the other. It's usually, what I have found is usually double outlet right atrium with unbalance at the ventricular level to the left. That's usually what we see, and those patients tend to be able to have a two ventricle repair. When the right side is the small side, I didn't even get into that. We have more options, because we can, give the patients additional sources of pulmonary blood flow if they need to, if their RV is inadequate. So we have a lot more options in that scenario. But I haven't found that to be a major issue. Have you found that to be a major issue, Fran?
No, not at all. Because as you say, the surgeons can deal with it. I think I was always more wondering about what it does physiologically, even in utero and during those first few months of life, and whether it in itself was just some kind of marker of either imbalance or had some implication for, worse AV valve regurgitation, or just something else that might, help us know how these patients would do.
Yeah, I think the ones that have that unbalance with the double outlet right atrium and the unbalanced left, it's hard to know if the right ventricle hasn't grown because the flow is all going into the left ventricle in utero. So that may be the case for sure.
I agree.
I'm going to be tempted to just ask one more question, because
Sure.
because one of your slides was how it's a very much a continuum and a spectrum, but the decision making at the end of the day has to be dichotomous. But I wonder, at least from our anecdotal experience at the Cleveland Clinic, we've really tried to say that it doesn't have to be black or white, that in some of those borderline LVs and unbalanced AV canal, we've certainly explored in a couple patients doing a 1.5 ventricle by converting the LV, the smallish LV, into a subpulmonary ventricle. So we do a Glenn, a hemi-mustard, and an LV to PA conduits with some good short-term results. But I wonder if we should start thinking more and more about that, rather than make it really of a black and white situation. I don't know what your thoughts on that would be.
Yeah, it's, I think it's a very innovative idea and strategy that to sort of go the other way on this. But I think the jury's still out on those types of things. And, a hemi-mustard has consequences. Making the RV the systemic ventricle has consequences. The right AV valve then becomes the important part of the scenario. And we know that side leaks too sometimes, that we don't think it's clinically important when the left ventricle is the systemic ventricle, but it's going to become important if the right ventricle is the systemic ventricle. Similar to other things, short-term outcome is great, but I think we need some more time to see if that really is going to be an effective strategy. Since we don't have good solutions to this problem, I think it's great to try.
Awesome. With this great comment, I think we can move on to our next talk. It's my pleasure to introduce my colleague and my friend, Dr. Fran Ehrenberg, and she's going to be talking to us about hearts along the hypoplastic left and right heart spectrum. Fran, the podium is yours.
Thank you, Malik. Thanks for everybody. So I'll talk about hearts along the hypoplastic left and right heart spectrum because it's a big topic. I'll focus a little more on the left heart. So these are the questions that I sort of think about when we decide or when we think about hearts that have some degree of hypoplasia. How big is big enough for septation? What are the key factors in septation decision-making? What imaging is optimal for these patients? And is the decision strategy that we make at birth forever? So here in this first panel, you see a heart that's obviously got some degree of hypoplasia. The LV is not apex forming. You can tell that it's smaller than the right ventricle, but it sort of has that feel that this, may be a keeper, and we can probably use this left side of the heart. In the middle panel, we see a patient with mitral atresia. It's also aortic atresia. So obviously this is a hypoplastic left heart syndrome, is going to be a single ventricle. And then we have the patient in the third panel that's clearly got significant left heart hypoplasia, but this is an echo at birth. There may be some issues with sort of loading and filling, and I think those are the hearts that give us more challenge. So people talk about the hypoplastic left heart complex, or sometimes we just use that catch-all Shones complex, as opposed to hypoplastic left heart syndrome. These hearts have important LV hypoplasia, but they may have the potential for biventricular repair. So we have these 4 classic papers that, despite their, sort of not complete applicability to all of our patients, we use to guide decision-making in left heart hypoplasia. I'll briefly discuss, not the whole papers, but what are the key anatomic features that each uses to guide the decision for biventricular or univentricular repair. So as we know in the Rhodes criteria, the main key features were the long axis ratio of the left ventricle, the aortic root size, the mitral valve area, and the LV mass. In the CHSS-1 data, relatively similarly, the aortic valve Z-score, the LV length, and then additionally the ascending aorta, the presence of moderate or severe tricuspid regurgitation, and the presence of EFE. The discriminant score was a reanalysis of the CHSS-1 data with additional patients and assessing measurement variation impact. So similarly looked at aortic annulus Z-score, LV to heart long axis ratio, and EFE. And then the CHSS-2 data focused on mitral valve Z-score, again, heart long axis, LVOT diameter, and mid-aortic arch. So here we see a heart with some at least mild LVOT and aortic hypoplasia. We would measure aortic valve right here, our root right here. Here we have a heart just demonstrating how we measure that long axis. So we measure from the crux of the heart to the apex of the heart, whatever it's made up from, and then we measure the long axis of the LV itself. Here's how we measure the mitral valve, which is obviously fairly hypoplastic in this heart. And this is just sort of a summation showing what are at least some of the similar features between all of these criteria and indices for left heart hypoplasia, really most focusing on something about the mitral valve, the LV size, particularly long axis, and aortic size, with some additional measurements of arch, tricuspid regurgitation, and EFE in some. So what about in the fetus? Obviously, many of these patients come to our attention during fetal life. So in this paper from Dr. Hornberger, the strongest predictors of need for single ventricle palliation were similarly to the children, mitral valve annulus size, the LV length Z-scores, and then left to right foramen-ovale flow. In this paper from Texas, they showed that exclusive left to right foramen-ovale flow at 32 weeks or greater was the highest predictor of the need for some type of neonatal surgery. 0% of patients who had that underwent no surgery. In other words, everyone underwent some surgery. 22% of those who had a biventricular surgery of some type had left to right PFO flow, but 88% of those who had single ventricle palliation had left to right PFO flow. And similarly, the strongest predictor of the need for a single ventricle repair was the mitral valve Z-score of less than negative 3.6, and 70% of, that was a 70% probability of single ventricle palliation. So is echo enough? I think in the modern era, it's probably not, and we frequently use CMR and CT. So in this paper, CMR was done in the first week of life, and those who had biventricular repair had an LV end diastolic volume index of at least 25 millimeters per meter squared, and ascending aortic flow of at least 2 liters per minute per meter squared. And those who had a single ventricle repair had an LVE DVI of less than 18 millimeters ml per meter squared. So obviously there is a little bit of a gray area in there, and those are our hardest patients. In this paper from Boston Children's, they proposed sort of a strategy for the hypoplastic left heart complex based on CMR and CT, proposing an initial stage 1 repair followed by LV recruitment, and then proceeding to biventricular repair if the LV end diastolic volume index is at least 40 and the LVEDP less than 13. And then showing that the LVEDVI at least 22 milliliters per meter square and an LV to RV stroke volume ratio of 0.19 seemed to be the minimum for biventricular repair. So switching briefly to right heart hypoplasia, similar to the left heart, the valve is really the key, and tricuspid valve annulus size seems to be the key. So in this paper from Dr. Basha and group, a Z-score of -2 to -3 seemed to be the cutoff for biventricular, as opposed to a 1V or 1.5 ventricular repair. A Z-score of the tricuspid valve less than 4 seemed to correlate with the unipartite ventricle. -2 to 0 correlates with the tripartite ventricle. And then again, that gray area of a Z-score of -2 to -4 had variable degrees of RV hypoplasia. In a meta-analysis done looking at multiple papers up through 2017 that looked at tricuspid valve Z-score in pulmonary atresia with intact septum, the Z-score of -2.8 seemed to be sort of the cutoff for biventricular repair in most of the studies. And these authors did point out that Z-score sets sometimes varied among papers, and obviously we've tried to approach that with the new PHN Z-scores. So we can look at this in the fetus as well. And in this series of fetal echoes in either pulmonary atresia with intact septum or very severe PS, the tricuspid valve was again the key, and the tricuspid valve size was consistently smaller in those who ultimately had a single ventricle repair, but the tricuspid valve in the right ventricle grew in utero in those who were destined for a 2 ventricle repair. They pointed out that 2 ventricle repair was favored by those with a tricuspid valve Z-score of -3 or greater, similar to those other studies, and that presence of important tricuspid regurgitation and absence of coronary fistulae and subaortic stenosis were other predictors of 2 ventricle repair. So I wanted to show a case that we had recently. A 32-year-old woman came to us, G3P1, referred just over 20 weeks after an obstetric ultrasound, showed possible hypoplastic left heart syndrome. She had no significant medical history. There was no family history of congenital heart disease. So here you can see a 4-chamber with and without color, and you can see that there's one of those long, skinny LVs that certainly has some degree, probably moderate hypoplasia, probably bidirectional shunting at the foramen ovale. In the 3-vessel view right here, SVC, pulmonary artery, aorta, you can see that there's a significant size difference between the ascending aorta and the pulmonary artery. So we saw her back at 25 weeks and had really a pretty similar looking heart. The mitral valve Z-score was -3.5 and the aortic valve Z-score was -3.8. So we saw her back at almost 32 weeks, and you can see that again, the heart looks pretty similar. The LV may be growing, but only in proportion to the rest of the heart. It certainly hasn't improved. And there was probably mild to moderate tricuspid regurgitation as shown in that panel. And then there was left to right atrial level shunting, as you can see here. The mitral valve Z-score was negative 4.1 and the aortic valve Z-score negative 3.3. So, you know, a bit of growth, but no catch up and no improvement. At birth, the heart looked pretty similar to how it did in the fetus, with this sort of long, skinny left ventricle that has, you know, some significant hypoplasia to it. The aortic annulus was again moderately hypoplastic as well, and there was severe transverse arch hypoplasia with a critical coarctation and mild to moderate tricuspid regurgitation. The mitral valve annulus was 0.64 centimeters for a Z-score of negative 3.3, similar to the fetus, and there was a thickened and unicuspid aortic valve with an annulus of 0.42 and a Z-score of negative 3.66. So even though this wasn't a case of critical aortic stenosis, we sort of put it through our different indices, the Rhodes, the CHSS1 discriminant score, and CHSS2, and 3 of the 4, as you see, sort of counseled us towards a univentricular repair for this patient, with only the CHSS2 suggesting a biventricular repair. So we decided to get a little bit more information with a cardiac MRI. You can see the sort of 4-chamber view here and the short axis, both showing, again, that sort of moderately hypoplastic left ventricle. And the end diastolic volume index of the left ventricle was only 15 cc's per meter squared, as opposed to the right ventricle that was 94 cc's per meter squared. So based on all of our data, at 7 days of age, she underwent a Norwood with 5 millimeter Sano, had planned delayed chest closure, initially some overcirculation that we treated with afterload reduction and diuretics. And she really did quite well in the interstage with 1 readmission for COVID, but a pretty benign course. And she came to clinic for one of her usual visits at 3 months old. And we can see that although the mitral valve cell still has important hypoplasia, the left ventricle seems to be improved in size. And there was pretty good right ventricular function and some maybe mild left ventricular dysfunction. Up here, you can see that her atrial level shunt was relatively small. We didn't do anything to it initially, actually, at the Norwood, with the idea that we might try to, push her towards a 2-ventricular repair in a staged fashion. And then she has important tricuspid regurgitation, as you can see in the last panel here. So at 4 months of age, she was asymptomatic, but showed up to clinic and her heart looked like this, with biventricular dysfunction and particularly severe LV dysfunction. So on further imaging, we could see that there was aortic stenosis right here. This is the Doppler of the aortic stenosis with about a 40 millimeter peak instantaneous gradient in the setting of very poor LV function. And then what sort of looked like some type of arch obstruction right here. So her next step was a cardiac cath. She had a good cardiac index of 5 liters per minute per meter squared with a QPQS of 1.1. Mean PA pressures were 13 to 15 with an LA pressure of 10. Her LVEDP was a little elevated at 16, which is not surprising given the LV dysfunction. And she had a bit of a mitral valve gradient, but only 2 to 4 millimeters mercury. The aortic valve gradient was 35 on peak to peak, and there was no significant aortic regurgitation. There was anatomic appearance of a coarctation, but no pressure gradient across the aortic arch. So we decided to get a repeat MRI to reassess that LV size. And of course, you can see the significant dysfunction that we now know is probably on the basis of this aortic stenosis. but the end diastolic volume index of the LV was now 48 cc's per meter squared, compared with obviously a significantly dilated right ventricular volume of 153. And the LV mass index was 33. So she went back to the cath lab for a valvuloplasty. The baseline gradient was 35 millimeters mercury, initially a 5 millimeter balloon, which really didn't do much. And so a repeat valvuloplasty with a 6 millimeter balloon reduced the gradient to 18, and no significant gradient was seen across the arch. And actually, not a lot of aortic regurgitation either. So we sort of looked at her data comparing birth and the now 4 months. We saw that her mitral valve annulus and aortic valve annulus grew a little, although not that much, and still have a z-score of kind of -4. But her LV volume grew significantly from 15 to 48, and her LV to RV ratio went from 0.15 to 0.3. So we sort of reanalyzed her through all of those different Rhodes criteria, CHSS1 criteria, et cetera. And all of them actually predicted now that she should undergo a 2-ventricle repair. So post-cath on echo, we saw improved biventricular function. This was actually relatively recently, so she still has some degree of LV dysfunction. The RV function significantly improved. The aortic stenosis gradient by echo is 27 and a mean of 16, so pretty similar to the post-cath findings. There's only trivial aortic regurgitation, and our current plan is to await, hopefully, further recovery of the ventricular function with the potential for a biventricular repair in this baby. This is a case of hypoplastic right ventricle. This was a twin gestation that was referred for suspicion for congenital heart disease in fetus A. So this is actually late gestation. We actually followed her throughout the whole pregnancy, but for the sake of time, I showed only a few pictures from 35 weeks. You could see a normal left ventricle right here, a severely hypoplastic, hypertrophied, somewhat hypoplastic and dysfunctional right ventricle right here. Her pulmonary artery and pulmonary annulus size are really quite normal, but there was pulmonary or near pulmonary atresia with a very, very little bit of flow through it. So at birth, the echocardiogram looked pretty similar, normal appearing left side with a sort of moderately hypoplastic and severely hypertrophied right ventricle with poor function. The tricuspid valve is not opening very much, but that's sort of hemodynamic, not anatomic, and the tricuspid valve z-score was -1.7, so fairly good in size. Here again is a picture of the pulmonary valve with a fairly normal looking annulus and sinus size, but no excursion of the leaflets. So she underwent a pulmonary balloon valvuloplasty. And you can see after the valvuloplasty that the leaflets are still quite thickened, but there's now antegrade flow. Despite a technically good valvuloplasty and opening of the valve, she was still blue and had been maintained on prostaglandins. So she underwent a PDA stent and was followed for several years with good patency of the PDA stent. Saturations in the usually high 80s, kind of because of right to left atrial level shunting, but clinically did quite well. Then she came to clinic recently. She's 6 years old, and the right ventricle has grown reasonably. It's still muscle bound, but that hypertrophy we saw as a neonate is not there anymore. The tricuspid valve opens well. There is significant right atrial dilation, as can be seen here. And then for the first time, the PDA stent was no longer patent. You could see the pulmonary valve, however, is patent with unobstructed antegrade flow and also free regurgitation. And the tricuspid valve z-score now is really normal at -0.2. So more to be determined on her. But in summary, biventricular repair is really guided largely for the left ventricle by mitral valve size and the LV long axis ratio. For the RV, it's generally about the tricuspid valve size. And of course, I didn't get into it, but a 1.5 ventricle repair is an option. So we have a little bit more flexibility when it comes to right ventricles that are somewhat hypoplastic. I think it's important to remember that ventricular size at birth is not always predictive of the ultimate size, as we saw in our patients, and that recruitment may be possible. Imaging certainly plays a key role in determining the adequacy of the left or the right heart. Many of our current guidelines and data are based on echo, so it obviously remains an important modality, but CMR can help with ventricular quantitation and LV mass calculations. Thank you.
Thank you, Fran. That was a great talk, and we'll encourage the virtual audience to bring up any questions they'd like to. Yeah, we're going to move on, but feel free to type your questions, and we're going to tackle them all at the end.
Okay, so I would like to introduce Dr. Jennifer Kovu, who has spoken several times at our conference already and probably does not need a reintroduction, but she comes from the University of Florida, and she will speak about the challenges to septation in heterotaxy.
All right. So I have no disclosures. Thank you again for having me in this talk. Little about the objectives. We will tackle the imaging considerations for heterotaxy. As you can see in our agenda and all the topics here, the unbalanced AV canal, the left hypoplastic left and hypoplastic right, the straddling mitral valves, the double outlet right ventricle, the transposition with LV outflow tract obstruction. Put them all together, heterotaxy. So all those little things and all the papers, you can't find any one paper that will say, oh, heterotaxy, and these are the rules for septation. No, so I think the take-home message for this is you take the most or the worst of the heterotaxy, or what is part of your heterotaxy, and use that, and use those rules from the hypoplastic level, from the unbalanced AV canal. Those are what you could use now. But what I can do today is probably do a little review of heterotaxy, because knowing the diagnosis will help you try to determine what type of surgical palliation or surgical repair this patient needs. So as you know, heterotaxy is an abnormality where the internal thoracoabdominal organs demonstrate an abnormal arrangement across the left-right axis of the body. Again, outside, we are very mirror imaged. If you divide your outside of your body, you are very symmetrical. Inside your body, you have this normal asymmetry. So this heterotaxy does not include complete situs solidus or complete situs inversus. And it just came from the word heteros. I think it's Latin for other, and taxis or order arrangement. So it's other order arrangement. So again, normal outside of the body, your left ear is mirror image of your right ear, your right hand is mirror image of your left hand, your right foot is mirror image of your left foot. But inside your body, your organs have this normal asymmetry, that not even your lungs, your right lung and your right bronchus is not a mirror image of your left lung or left bronchus. Same thing with the heart. I've said this earlier, your right ventricle is not mirror image of your left ventricle. Same thing, your liver is on the right, your spleen is on the left, your stomach is on the left, and even the corrugations of, or the way the rotation of your small bowel and your large bowel is a certain asymmetry, a normal asymmetry to it. So the incidence of heterotaxy is 10 to 14 in 100,000 live births, which is around 2.3 to 4.2 of congenital heart disease. And there's highest familial recurrence rate of all cardiovascular malformations. Again, most cases are non-syndromic except for the heterotaxy itself. It's not combined, as we know, though with the advent of the whole exome sequence, I think we'll know further in the future what this entails really. So you can either have right atrial isomerism or asplenia syndrome, left atrial isomerism or polysplenia syndrome. Again, isomerism means iso equal, meros part, and that your normal internal asymmetry is lost. So what happens is you develop asymmetry, an abnormal developmental symmetry. So there's a loss of a distinct left and right side, and there's a duplication of right or left side. So again, for me, I think I fell in love with pediatric cardiology when heterotaxy made sense. That's like, because every time when I was a pediatric resident, they give me heterotaxy and I'm like, oh my God, I'm overwhelmed. There's a canal, there's an arch issue, double outlet right ventricle, malpose, great vessels. Why don't you just say it all? And all this patient has it. But when I found out that it is just a duplication of one side or the other, it all made sense. So left atrial isomerism is a duplication of left-sided structures. Again, maybe too simplistic, but there's a method to this madness. So your spleen is on the left, therefore you'll have multiple spleens, and this is why it's called polysplenia syndrome. These spleens but these spleens are mostly functional asplenia, meaning it's not going to be functional even though there's many of them. Right atrial isomerism is duplication of the right-sided structures. Your spleen is on the left, there's no spleen on the right, you duplicate your right, then therefore you won't have any spleen. That's why it's also called asplenia syndrome. Does that make sense? So in right atrial, let's now talk about right atrial isomerism, asplenia syndrome. Usually, so there are right-sided structures in your heart that is normally very identifiable as the right side. You're normally connected inferior vena cava. Your pulmonary veins draining to another large vein because it's duplication of right side. Where are your pulmonary veins? In the left atrium. Therefore, you duplicate your right atrium. There's no pulmonary veins there, so therefore you'll have total anomalous pulmonary venous return. There's usually an AV canal, but that's not very indicative of either right atrial isomerism or left atrial isomerism. It's usually associated with transposition of great arteries. That's why we're here in the transposition of great arteries master class, and double outlet right ventricle with pulmonary stenosis. In left atrial isomerism, however, since the IVC is on your right atrium, you duplicate your left atrium, therefore you'll have an interrupted IVC because you have no IVC. The IVC is a right heart structure. Your pulmonary veins could drain to the left atrium, could drain to the right atrium instead of the left atrium, or you'll have ipsilateral veins, which we will show later, or there'll be a common single AV canal, again, not indicative of either right atrial or right or left atrial isomerism. And most left atrial isomerism is associated with normally related great vessels exiting the heart. So where to begin? Very, very overwhelming. You do the transthoracic echo. A fellow goes in the middle of the night and just cannot believe what she's saying. She saw there's a lot of defects. But if you do your normal exam systematically, then you won't get lost. So you start with abdominal visceral situs, and then you start with your cardiac analysis. Where's the position of the heart in its apex? Is it levocardia or dextrocardia? Where are the veno-atrial connections, including hepatic veins? Is IVC interrupted? Look for the coronary sinus septum. look for your atrial septum. Is it there? Is it absent? Is there a common atrium? And arrangement of the atrial appendage. Again, it's duplication of the right atrium, left atrium. So it's right atrial appendage, there's two of them, and then the left atrial appendage, there's duplication if there is left atrial isomerism. And again, where are the AV canal junctions, or where are the AV junctions? Likewise, look at the ventricular topology, where sure is your morphologic right ventricle really the right ventricle, and likewise your morphologic left ventricle, is it on the left? Where's your ventricular arterial connections? Is it maltransposition of great arteries? Are they double outlet right ventricle, malpost great arteries? And you look at your pulmonary and aortic blood flow and outflow tracts, and is there presence of obstruction? And lastly, your aortic arch-sidedness and branching patterns. So again, this is just a cartoon of how a situs solitis. This is your normal situs solitis from your abdominal subcostal view, where the IVC is on the right and the aorta is on the left, and then inverses, the IVC is on the left and the aorta is on the right. But again, it's not heterotaxy does not include complete situs inversus. So in right atrial isomerism, your IV could be your IVC could be near the aorta on the left, or your IVC can be with your aorta on the right. Likewise, your left atrial isomerism, there's no IVC but an azygos. So again, right atrial isomerism, your atrial anatomy shows your atrial appendage. Your usual, there's a broad base appendage on your right, and then a finger-like appendage on your left. In right atrial isomerism of right atrial appendage, there's two broad base appendage. Again, how would you remember those who were trained like around my era? Snoopy snout, Snoopy's ear. Snoopy snout is the right atrial appendage. Snoopy's ear is your left atrial appendage. And you would see that the atrial septum is typically absent, and there are large primum and secundum defects separated by thin septal strand. This is one of those AV canal defects where you could see just like a floating atrial septum almost. Again, your systemic venous return in right atrial isomerism, it's total anomalous pulmonary venous return until systemic venous return. There's usually bilateral SVC. Now, left atrial isomerism is the same. It occurs in 50 to 80%. And your IVC is intact. Some of them have absent coronary sinus. And you look at your pulmonary venous return, typically drains anomalously to extracardiac structures. That is, you rule that out. That is a given until proven otherwise. Again, I don't need to tell this audience about supracardiac veins, infracardiac veins, you know those. And again, this is your transthoracic echocardiogram, four-chamber view of total anomalous pulmonary venous return. You could see that if you see this structure on the left, up like near the left-sided atrium, where there's that little wall, and you cannot prove that there's pulmonary veins both by 2D and color, then it's total anomalous pulmonary venous return until proven otherwise. Now we look at AV canal junction, or the atrioventricular junction. It's usually both left atrial isomerism and right atrial isomerism is associated with AV canals, and 62 to 78% of right atrial isomerism is associated with D-looping, and the rest are univentricular. So again, you could see that this is the ASD here. It's huge, it's large, and you could see that there's a VSD as well, but there's an AV canal here. This is the left ventricle and the right ventricle. This is just another four-chamber view where you see that this is an RV, and you could see there's a common atrium. You can't even see the atrial septum, and this is the right ventricle, and this is a hypoplastic left heart variant where there's left AV valve atresia. And now let's go to the great arteries. 85% of right atrial isomerism is associated with pulmonary stenosis or pulmonary atresia. 90% may be double outlet right ventricle with, again, pulmonary atresia. And of both right atrial isomerism and left atrial isomerism, remember, left atrial isomerism is associated with normally related great arteries. Right atrial isomerism is the one that has malposed great arteries, and it's not that huge. It's 12.5%, and 11% aorta is left of the PA, and on 1.4% aorta is right of the PA. Let's now switch gears and go talk about left atrial isomerism. When the left atrial appendage looks like finger-like appendages, and in isomerism of left atrial appendages, there's two Snoopy's ears on both sides. Again, atrial septum could be intact. There's a PFO, or again, there's common atrium. This is an example of left atrial isomerism where there's a common atrium. And again, this is your morphologic right ventricle, morphologic left ventricle, and they're thickened. But one thing that you could see here is your pulmonary veins, and they are not they're not anomalous. So your systemic venous return, like I've said, bilateral SVC, it occurs in both isomerisms. This occurs in 40 to 50%. But what is pathognomonic of left atrial isomerism is an interrupted IVC, because your IVC is a right atrial structure, and your hepatic veins would enter your right atrium. You could also see that your pulmonary veins could either enter normally on your left atrium, like my other image, or it could be it could drain in the right on the left-sided atrium, and two could drain in the left-sided atrium, and two could drain in the right-sided atrium. These are called ipsilateral pulmonary venous return, which occurs in 50%. And this is just the right atrium here, left atrium here. This is the atrial septum. The right pulmonary veins enter the right-sided atrium, and the left pulmonary veins enter the left-sided atrium. Now, AV canal can be seen in 50% of left atrial isomerism or polysplenia patients, and 1/3 of them have intact ventricular septum, and you'll just have a common atrium. 80% is associated with D-looping, and again, great arteries. Only 20% are associated with pulmonary stenosis or atresia, and they're usually associated with coarctation of the aorta or left-sided obstruction in 20 to 45%. 37% may be double outlet right ventricle, and only around 8% has transposition of great arteries, and most are normally related great arteries. This is from one of the papers of Dr. Cohen, and you could see here right atrial isomerism syndrome and left atrial isomerism or polysplenia, and you could see these are the different types of defects associated with both. And let me just, since this is a transposition of great arteries master class, the transposition of great arteries associated with right atrial, more associated with right atrial isomerism, up to 75%. There's a study where they looked at all the laterality defects in the group of heterotaxy syndromes or an outflow tract malformation, and this is just to see that in all comers of transposition of great arteries, the left atrial isomerism is not associated with any of transpositions, less than not never, but less than the right atrial isomerism. Here too, you could see those heterotaxies with left arch and right arch. Most transposition of great arteries are also associated higher with the right aortic arch and then the left aortic arch. There are also abnormalities with the conduction system, because sinus node is typically seen in the morphologic right atrium. So in right atrial isomerism, there's duplication. You could see duplicated sinus node. You could see two sinus node firing. Or in left atrial isomerism, you could see an absent sinus node, and you would see inverted P waves. So they're usually associated with sinus node dysfunction and atrial arrhythmias. And these are the patients when you see in fetal life who has sinus bradycardia and has a lot of defects, AV canal, double L right ventricle, then it's left atrial isomerism until proven otherwise. If they have normal rhythms, we are prepared. We counsel the parents that these patients inevitably may need the pacemaker, so they're prepared. Same thing, again, method to this madness. Isn't this wonderful? Right lung has 3 segments, and left lung has 2. And in right atrial isomerism, there's duplication of right lungs, and the right bronchus as well. And your stomach is usually on the left, but you are asplenic on the left. If left atrial isomerism, there's duplication of the left lung structures. Your stomach could be on the right. Your liver could be on the left or midline. And again, you have polysplenia, which are really functionally asplenic. Again, want to thank Diane Spicer for these images. Again, you could see bilateral morphologic right bronchi seen in right atrial isomerism, and bilateral morphologic left bronchi in left atrial isomerism. You could see here as well the lungs and right atrial isomerism. There's bilateral right lung and bilateral left lungs on left atrial isomerism, which is, again, the right lung is trilobed and left lungs is bilobed. Splenic morphology is usually in right atrial isomerism, there's absent spleen. But again, the presence of spleen is not indicative of either one. They can still be right atrial isomerism and left atrial isomerism even with the presence of spleen. But it's just associated with left atrial isomerism is associated with multiple spleens. But you could see here in right atrial isomerism, you could still see multiple spleens, solitary spleen, and left atrial isomerism, you could see absent spleen. So let's now switch gears and look at prenatal assessment. And usually the reason for referral is abnormal position of the stomach and or the heart, or fetal bradycardia, as I've previously mentioned. The fetal diagnosis of heterotaxy has improved over the last few years, and the screening has improved as well from our MFM and OB colleagues. And again, follow the same comprehensive approach. Determine the fetal lie-in position, identify the systemic and pulmonary venous connections, identify the atrial appendage, and identify the intracardiac anatomy. This is just identifying your fetal situs. Again, this is posterior, this is anterior, and you can see that this heart is mesocardic. And you could see here that there's an AV canal based on the sweep. And this is just a bicaval view. And so you see an IVC here. What do you think this is? And what am I showing? There's turbulence of flow in the IVC. Infradiaphragmatic total anomalous pulmonary venous return and right atrial isomerism. Again, until proven otherwise. That's like high in your suspicion. So it's really important to arrive at an accurate diagnosis even in fetal life. Why? Because it's important to provide appropriate family counseling. Your first counseling could stick forever, and they might not want a biventricular repair in the future, or they might want a biventricular repair in the future, depending on how you counsel. So again, delineate all management options for the families as to which one are you going to use in terms of septation. You need to know which one is the predominant problem. Is there a straddling valve? Is there an unbalanced AV canal? And use those is there a hypoplastic left heart syndrome? And use those strategies to arrive at the perfect and of course discuss with your team and arrive at the appropriate and hopefully appropriate surgical palliation or repair based on what is the predominant lesion. Again, the preoperative assessment, you need to have a thoracic echocardiogram and checklist as I previously shown you. And you may need other imaging modalities. I'm a multimodality imager. Cross-sectional imaging nowadays is almost needed. Again, cardiac CT is easy in our center. You don't need sedation, and it's 0.25 seconds for a whole heart, and we have a good helical scan that can do this really quick without sedation, even with babies or even 2-year-old children. And you can see here there's bilateral trilobed lungs or bronchi, and this is right atrial isomerism. This is just a good picture of that infrared, same patient with infrared diaphragmatic total venous return with this like Christmas tree-ish pattern here going down the vertical vein to your draining to your IVC. Again, this is, you could, what the other advantage of multimodality imaging, cross-sectional imaging, is you could do multiplanar imaging, and this could help your surgeon as to preoperative planning. Again, this is just a nicer view of that total anomalous pulmonary venous return with the vertical vein drains to the IVC here. Cardiac MRI nowadays is really important, especially if you want to know if this hypoplastic left heart or hypoplastic right heart we can do biventricular repair or not, and ventricular volumes through an MRI is needed. And with cardiac MRI, you could also quantify using flow quantification valve regurgitation, and also in some the location of the VSD, which if it's remote, it's hard to septate. This is just one of our patients, and you could determine function, especially right ventricular function. You could quantify, and again, you could see where especially in milepost great arteries in double outlet right ventricle, you could see if the surgeon could baffle the left ventricle to the aorta. Again, with MRI, you could do multiplanar imaging and see everything, the aortic arch, if there's any coarctation of the aorta, and this would lead to better preoperative planning and a better decision. Lastly, we could do 3D printing. We outsource our 3D printing in our institution at University of Florida because they're faster, they're bigger, and it's quicker. We do help them plan these cuts and plan the printing though. And so this is just one with a hypoplastic right side structure. And this is one with milepost great arteries here, trying to determine if this we can baffle the VSD to the aorta. And this is a squishy model, what we call squishy. It's a more compressible gel-like 3D print where the surgeon can cutting through it however he wants before the surgery. Post-operative assessment focus depends on the type of procedure performed. Usually stage single ventricle palliation, especially if you can't septate for total anomalous pulmonary venous return. Individual veins require special attention, not just the septation, but if you have total veins that are bad or are stenosed, you will have lifelong issues. And ventricular function and AV valve regurgitation, as previously mentioned, is important. And again, post-operative assessment on what Dr. Cohen has previously mentioned about your residual AV valve regurgitation happens to everyone. This is my patient immediately post-op, but now she only has like trivial to mild AV valve regurgitation, left AV valve regurgitation. Again, another for post-operative management, again, you could see if it's a single ventricle variant, you could look at the function based on echo post-operatively, and also later on as we follow them up, you could see with this presence of AVMs. especially with those with interrupted IVCs. In summary, heterotaxy syndrome is an abnormality where the internal thoracoabdominal organs demonstrate abnormal arrangement across the left-right axis of the body. Comprehensive and systematic approach to diagnosis is warranted, and trying to identify what is the worst of all the combination of defects and prenatal assessment of heterotaxy has improved and is important in providing adequate counseling to the families, because your counseling would go with them to the future and based on and would resonate with them and will help them decide their future, their parents' future decision in terms of septation or biventricular repair. Postnatal diagnosis and preoperative assessment include the use of the transthoracic echocardiogram, cardiac MRI, or cardiac CT for better delineation of complex congenital heart disease, and postoperative assessment depends on the type of procedure performed. Again, if you want to screenshot this is just a great little infographic showing what is right atrial isomerism, left atrial isomerism, what is just common mirror imagery, and your usual normal arrangement of the structures. Thank you very much.
Sure. We were going to save them at the end, but if you feel like you want to, are you staying till the end? Okay, that's fine. Please go ahead.
Thank you for the nice presentation. My first case of right isomerism I diagnosed in 1997. I was in Prince Sultan Cardiac Center in Riyadh. The case was diagnosed as right isomerism with the obstructed total anomalous pulmonary vein drainage to infradiaphragmatic IVC. So at that time, I read an article which was published in the British Heart Journal from Birmingham. They published their experience with 12 cases of right isomerism. And they concluded at the end that all the patients were dead by 20 months of age. And then they concluded that there is no need to interfere with these patients.
And this is 1997?
Yeah.
Wow.
So I told my surgeons that this is the experience. And I got them the article. They said, no, we will operate. The patient was dead by 3 months of age. Yeah. So the last case, I had it maybe 5-6 years ago. No surgeon wanted to touch. Number one is to release the pulmonary vein drainage. This is life-saving. Right. And then pulmonary atresia, they put BT shunt. But because of asplenia, they cannot resist infection. They die because of infection.
Right now, what we do is we give them prophylaxis, antibiotic prophylaxis for asplenia until 5 years of age, until they get all their vaccines. And it's just, protecting from the encapsulated bacteria. But
things is different now.
Yeah.
But this is my experience.
Absolutely.
Well, that's nice to hear the history, and that's very humbling for us that that I trained leader, and I take this for granted that all my patients are alive and well and playing soccer somewhere, like making the team. And so
it's good progress.
Humbling.
Yeah, but your comments are
we need courageous surgeons to do that.
Yeah.
Yes.
Yeah. Yes.
Your comment is still very valid, because I think, if I remember, the Boston Children's long series of heterotaxy, they showed that the biggest causes of mortality are anomalous pulmonary venous drainage and also single ventricle physiology. And what was interesting is that the mortality did not actually improve over the surgical era. So I do think that, yes, absolutely, in this day and age, we offer to repair all of them, but that's not to say that there's still challenging cases. But obviously, we offer to repair them.
Thank you very much.
But thank you for sharing that. All right, well, we're moving along. So what we try to do in this workshop is to try to offer sort of different topics that all could offer challenges to achieving biventricular circulation for various reasons: hypoplasia, all the challenges of heterotaxy. And we thought the appropriate next topic on our list would be complex double outlet right ventricle, and how these cases can be very challenging to achieving biventricular repair. And I appreciate, again, my colleague, Dr. Ehrenberg, for stepping in and doing this presentation last minute.
Thank you, Malik. So I'm not Nick Suji, who unfortunately couldn't be with us today. This really is his talk, but I'll try to do it justice as I give it. So neither of us has any disclosures. And so we'll try to talk about the definition of double outlet right ventricle, variations of double outlet right ventricle, and imaging approaches to double outlet right ventricle. So when we talk about double outlet right ventricle, one of the definitions uses what we call the 50% rule. And so it has to do with the fact that this is a conotruncal defect and that one of the great arteries overrides the ventricular septal defect in the sort of classic conotruncal form. So in this panel over here with an overriding aorta, you see that if you just trace a line from the ventricular septum, greater than 50% of the aorta overrides the right ventricle. So we call it double outlet right ventricle. Similar over here with the subpulmonary VSD, more than 50% of the pulmonary arterial trunk overrides the right ventricle, and the aorta comes off of the RV infundibulum. So here you can see a typical echo picture like we might get with the ventricular septum right here and the more than 50% override. The other key feature that many use in definition of double outlet right ventricle is a lack of fibrous continuity or fibrous discontinuity between the mitral valve annulus and the semilunar valve annulus. So you can see right here the mitral valve, and the aortic valve starts all the way up here. So there's this fibrous discontinuity. VSDs can have variable location, the sort of classic the subaortic and subpulmonic, but we can also have non-committed VSDs and doubly committed VSDs. So in the subaortic VSD, in these 3D MRI pictures, you can see the VSD right here, which is subaortic. The physiology for subaortic VSDs is generally sort of either tetralogy-like or VSD-like, depending on the presence or absence of associated pulmonic stenosis. 68% of double outlet right ventricles have a subaortic VSD. Right here, you see the short axis with the large subaortic VSD right here, the anterior deviation of the conal septum, and this subpulmonic stenosis with the typical PS Doppler over here. Same panel showing the VSD and the sub-PS. This patient had so much subpulmonic stenosis that got a PDA stent right here as initial palliation. We can also have a subpulmonic VSD, as we see right here in these MRI pictures. Again, this asterisk shows us the VSD location, which is subpulmonic, and the aorta is sort of side by side, but off of the RV infundibulum. About 22% of double outlet right ventricles have a subpulmonic VSD, and these patients generally have transposition-like physiology. There's also the Taussig-Bing anomaly, which was originally described in 1949. Here's a sort of classic picture, again showing the pulmonary trunk, the double conus, and then the aorta anterior and to the right. We can have non-committed VSDs like we see over here. So here's the VSD. there's ventricular tissue right here, and then an aorta and a pulmonary trunk, neither of which are completely associated with the ventricular septal defect. Non-committed VSDs are the small subsets, usually sort of 5 to 10% in most cases. And the physiology can be variable, really depends on the relationship of the great arteries and where the VSD or VSDs are. Doubly committed VSD right here is under both the aortic and the pulmonary trunk with minimal conal septum. Doubly committed VSD in double outlet right ventricle is pretty rare, 3%, and again, the physiology can be variable. So outflow tract stenosis makes or plays a key role in the physiology of double outlet right ventricle. The artery that's not committed to the VSD tends to be the smaller one. And that's usually the rightward or anterior. So when that's the aorta, in this case of subpulmonary VSD with transposition-like physiology, there's risk of coarctation. So then we ask, are these patients suitable for biventricular repair? So there's obviously the issues of ventricular volumes, as we spoke about earlier, including that if we baffle the left ventricle to one of the arteries that comes off, or to the aorta generally, that comes off of the right ventricle, we're going to lose some of the RV volume. Ventricular function, AV valve size, VSD location, and the question about whether the baffle path is feasible are the key determinants. So here's a nice 4D MRI reconstruction where we try to estimate the post-op RV volume. So the LV is cut away in this picture. And you can, or I'm sorry, the LV is over here. You can see the site of this potential baffle over to the aorta right here. And so the LV volume was 53, the RV volume was 57, but by using this type of reconstruction, we can estimate what the volume loss will be to the right ventricle once the septation occurs, and it was down to approximately 40 ml per meter squared, or a loss of about 30%. So this patient, because of that, actually underwent a 1.5 ventricle repair. So you can see the LV tunneled over to the aorta in this long tunnel. There's no obstruction right here, but there is loss of volume in the right ventricle, as you see right here through that, because of that tunnel. So algorithms have been created for how to deal with a double outlet right ventricle with VSD. We'll talk first about the subaortic or non-committed VSD. So as we said, in those patients, here's the VSD right here. When we look at it in the orthogonal view, we see the LV tunneled by this long pathway over to the aorta. The sequela of that long LV to aorta baffle is obviously some type of obstruction. So you can see right here, and then see right here in the opposite view, how this long tunnel can be sort of obstructed as it's between other important structures. And right or left ventricular outflow tract obstruction occurs in about 30% of cases. So if we then look at subpulmonary or non-committed VSDs, again, we see right here a case of a subpulmonary VSD. There's a single coronary artery right here that you can see runs anterior to the great arteries. In this 3D picture right here, you could see the coronaries labeled. Unfortunately, babies don't come out with the coronaries labeled like this, but it's nice to be able to have these reconstructions that we can do and guide the surgeons. Lastly, we'll talk about non-committed or subpulmonary VSDs that have PS or so here's a picture right here of a case of a non-committed VSD. The VSD is down here, both great arteries are up here with some septum in between them. And this case was actually treated by a double root translocation, as we discussed yesterday, along with the relief of this subpulmonic narrowing right here. And because of that conal resection and the relief of that subpulmonary obstruction, sort of like we talked about yesterday, the neo-aortic valve actually was pretty adequate, and the LV2 aorta pathway was unobstructed. So special considerations can be the coronary arteries. Coronary arteries can cross over the right ventricular outflow tract. That happens that's important when we're doing a tetralogy type of repair. In the subpulmonary VSDs that are having an arterial switch, obviously we need to understand the coronary arrangement and what they're like, because that'll be part of the repair. And as we alluded to yesterday, in Taussig-Bing anomalies, the coronary arteries are often not normal at all and don't even align themselves to a typical right and left coronary artery. AV valve abnormalities can occur as well. There can be stenosis of the AV valve, most commonly the mitral valve, straddling or override, again, more typically the mitral valve. And there can be close proximity of the septal leaflets of the tricuspid valve to the VSD, which may be important in the repair. So here's an image right here where we do see a tricuspid valve right here that's in close proximity and has attachments right to the crest of the septum. This is a case of how we use 3D printing for planning for double outlet right ventricle repair. In this panel right here, two different sort of measurements are made of the LV2 aorta pathway. One would be the direct measurement, which is just the solid arrow right here, but the other is this curved measurement right here, which actually has more in common with how the actual pathway will be, because although there's a certain linear distance that we might measure by echocardiography, when the baffle is made, it actually tends to have more of this curved kind of distance and appearance to it. So the curved measurement that we can make actually lets you know how far and how long the pathway will be. This is just a cross-section showing the way to estimate the VSD size and whether it will be adequate. So this is a case where, again, virtual planning in double outlet right ventricle was used to assess whether the long tunnel from the left ventricle to the aorta would be adequate. And here's a tunnel from a VSD to the aorta. Here's a tunnel from a VSD to a pulmonary artery. And you could see how from these reconstructed 3D MRI images, we made a 3D printed model that the surgeons could use to look at whether the pathway would be adequate. This was a paper from the European Heart Journal that took two surgeons and had them review 10 different cases each of double outlet right ventricle with complex VSDs. And they were asked to plan the surgery based on CT, CMR type of images, a 3D CT or MRI image, a 3D printed model, or a virtual reality that they could work with of the same case. And I'll show this a little bit bigger, but basically from the CT, CMR data, they said that 75% of the cases could go on for a biventricular repair. From the 3D CT or MRI, pretty similar. 70% were felt to be able to go for a biventricular repair. Using a 3D printed model, slightly better. They felt 85% could go for a biventricular repair. And then using this virtual reality method where they could play around sort of with the heart, 95% were estimated to be able to go on for biventricular repair. So the conclusion was using this virtual reality type of model increased the ability to understand patients that could appropriately go on for biventricular repair with complex VSD and double outlet right ventricle. I think this just pretty much says the same thing. So in summary, preoperative imaging for a double outlet right ventricle requires a comprehensive evaluation of the anatomy. The feasibility of each surgical element has to be taken into consideration. Advanced 3D visualization techniques may improve the selection of biventricular repair candidates. Thank you.
Thank you very much, Fran. That was great talk. And now we will now introduce our next speaker, Dr. Lisa Hornberger, who is a professor of pediatrics and obstetrics and gynecology and the new chief of pediatric cardiology at Stollery Children's Hospital in Edmonton. She will be talking about transposition with complex LV outflow tract obstruction.
So I have to start by saying I very much apologize. Again, thank you for inviting me, but I actually didn't quite realize I had this talk until yesterday, and it was because I missed an email a little while back. So I quickly scrambled, and I will tell you that I'm really grateful to Jeffrey Smallford and Nico. This part of the talk is going to be semi-short, so my sincere apologies, and it's because I had to get images sent from my colleagues, Jeffrey, who's retired, in fact, and was off to the swimming pool, and was willing to send me a talk on transposition, and he had some pictures there. And then Dr. Koo, who's amazing with 3D and had been trained under Jeffrey, actually had just a couple cases. So I will give you what I got. And then I'm going to give you a little surprise at the end. That's a fetal case, of course, but not necessarily about this topic. So, of course, we love to see a beautiful little left ventricular outflow tract and a great pulmonary valve and a normal transposition, even with a ventricular septal defect. As you can see here, the aortic valve is quite normal, and the pathologic sample from many years ago looks the same. So there's no outflow obstruction. But every once in a while, you do get into trouble with left ventricular outflow tract obstruction. And not all of it is bad. Some of it can be dealt with even with an arterial switch, of course. But some of them require other configuration, other surgical interventions. And some are really not kind of reparable with respect to a biventricular circulation. So you have dynamic lesions. You can have tissue tags. You can have valvar pulmonary stenosis, fibrous subpulmonary stenosis, posterior deviation of infundibular septum, a tunnel subpulmonary stenosis, usually with an associated left VIF, and then accessory AV valve tissue, some of which you can manage and some of which you can't manage. Depends on whether it's an important part of the valve and whether it really causes significant obstruction. Straddling, which is a tough one and where I think 3D models actually can be very helpful. But 3D imaging by echo we've used quite a bit. And then you may have some combination of all of these. So it's really important that we really meticulously look at the LV outflow when we think that there's LV outflow obstruction. 2D is certainly still the foundation. You start there. If you don't see anything obvious, or it's more just posterior malalignment and valvar lesion, we don't move on to more higher levels of echo. But when we get into more complex lesions, we certainly are using more and more 3D echo. But you want to do meticulous 2D and color Doppler long and short axis sweeps. With 3D echo, again, we're looking at more complex AV valve anatomy and more complex left ventricular outflow lesions to get a better sense for whether, what can be done. And can the heart be septated? And certainly this has assisted our surgeons. They won't go to the OR without 3D imaging of anything more complex. And then cardiac MRI, and some are using 3D as well for valve and outflow anatomy, but also ventricular volumes. And then the 3D models we've increasingly used. Unfortunately, I didn't have a chance to bring an example, but we've had some that I would have bet my career they couldn't septate. And with the 3D models, we absolutely showed that they could be septated. Doppler assessment in this context, you always have to be a bit cautious. It's important, and we'll use pulse sampling all the way along the LV outflow and CW Doppler. But some of it, you may not have a big gradient when there's a large duct and high PVR and VSD, so you have to kind of watch. But as the PVR falls, you may see a gradient that doesn't necessarily just reflect obstruction, because, of course, that's where pulmonary blood flow is going. And if you have VSD, you've got increased flow that may actually give you a higher gradient than really exists with respect to being able to predict your PA pressures. So, of course, this is one case in which the LV pressures are down because this patient presented a little bit late and the duct was starting to constrict, and you've got this sort of dynamic subpulmonary obstruction in the LV outflow, but it's just from membranous septum, or it could be aneurysm of membranous septum associated with, or even AV valve tissue associated with a ventricular septal defect that's causing dynamic obstruction. And in fact, this baby has quite good sized pulmonary valve, and this is going to go away once the arterial switch has been done. This is another simpler case where you've got a good sized pulmonary valve. It looks pretty normal, but you've got tissue tags that is billowing from the anterior mitral valve leaflet into the LV outflow and creating obstruction. Fortunately, this is one that can be easily resected. This is not the same patient, I should say. This is an old one from Jeffrey's slides. So that's one that can be simply resected and not a problem. This is kind of an interesting one just because it's a doubly committed ventricular septal defect. So you're seeing the semilunar valves almost right on each other. And then the aorta is slightly overriding that VSD. And that's probably because there's a bit of posterior malalignment, but there's not really much in the way of conal septum, and the obstruction's all at the valve level here. So that's a pulmonary valve stenosis, and we would measure the valve diameter and get a Z-score, and then talk to the surgeons about what they're going to do in terms of, should they just go from LV to AO and do something with the pulmonary outflow, or if the pulmonary valve is sufficient, they might still do an arterial switch. Really depends on that lesion. So this is another form of left ventricular outflow tract obstruction where you have a disconnect. Of course, the left VIF or a subpulmonary infundibulum separating the anterior mitral valve leaflet from the pulmonary valve itself. And it's a nice doming, quite small pulmonary valve, and there's also a bit of fibrous tissue in the subpulmonary area. So this is one that we would be considering. In fact, certainly not a Rastelli when this baby has quite dynamic and not a very big ventricular septal defect. This is one that we would be considering a Nikaido. Make sure the baby has a good sized atrial lobe communication and sufficient pulmonary blood flow. Send them on their way and then bring them back. This is just the 3D of that VSD where, in that one dimension, it looked not that bad. In the other dimensions, it's quite dynamic. And so this is not one that you're going to want to rely on for a Rastelli. So that's one that we would try to send on their way and bring them back for a Nikaido at a later stage if the coronaries are sufficient. This was just an interesting case, but it's one with posterior malalignment of conal septum. Unfortunately, I couldn't get this to play faster no matter what I did, but this was one that you'll see that there's some pulmonary outflow obstruction here. The hardest part about this baby was quite a complex VSD, which we'll see from the other images, where this big muscle bar going straight across the VSD, and the surgeon was not really happy to do very much with it early on. So we'll see this a little bit better. You can see that there's going to be some narrowing of the subpulmonary area, but this VSD, there's a huge anterior muscular VSD as well as a paramembranous defect, but the anterior muscular one I'll show you was quite tricky, and the one that really affected what they were going to do. 4 chambers looked quite normal. But there you can see your posterior malalignment, your long axis, and the pulmonary valve is a little bit on the smaller side, but not so small. It's about 7 millimeters relative to about a 10, 11 millimeter aortic valve, but the VSD was quite big. And so with this baby, they weren't, of course, wanting to do a Nikaido as a newborn. They prefer doing that several months of age. But there's a fair amount of sub-PS, and then this ventricular septal defect was a bear. This is just showing you that it was a bicuspid pulmonary valve, not terribly small. But what you're seeing as you go down is this muscle bar that was very bizarre. It went from the left ventricle into the right ventricle, didn't have significant AV valve attachments on it, but sort of separated that large VSD into kind of 2 orifices. That was a little bit tricky, and that VSD went all the way up anterior and was quite large. This baby initially was pink enough, so we were letting the duct close, and the baby became quite a bit bluer. And fortunately, the duct was still patent, and they were able to put a stent in the duct to buy some time. And again, the atrial septum, we always want to make sure that the baby's mixing sufficiently as well. But this is one more image of this VSD that has been a problem. Our surgeon was hoping to buy some more time because the VSD was a bit more complicated. This is really strange, and honestly, I hadn't seen one like this, but was worried. There was this just sort of muscle. I don't know if it's just went straight across through this very, very large hole. And our surgeon was quite worried about doing a big Nikaido procedure and then trying to septate the heart. So in fact, this baby ended up having a Glenn as a second stage and is going to come back another day for hopefully further work. This is a more classic, although you can see this is more complicated in that there is a sort of left BIF here separating the mitral valve anterior leaflet from the pulmonary valve itself. The pulmonary valve itself is quite small, and there's posterior malalignment, a very large, normal appearing aortic outflow, and the VSD is probably fairly in a reasonable place for a potential Rastelli. They like to do 3D in our program, and this is your little pulmonary outflow, and it just shows you the pathway from the left ventricle into the aorta that would be prime for a Rastelli. So sometimes you do have AV valve tissue, and honestly, I've seen a couple of times folks try to resect this in newborns, which doesn't work well. So if there's a mitral valve attachment to the septum, probably best, even if you think it's probably not important for mitral valve function, to leave it alone. And when we've done that, we've had babies get out that they can then address whether that's something that they can actually resect or move if it's something that's important for the mitral valve. But I think if you do something as a newborn, you run the risk of having a mitral valve that ends up needing to be replaced, which I've seen happen twice in 2 big centers. So this is actually where the LV outflow and pulmonary outflow would be. And this is actually part of the mitral valve that's sitting up from with a cleft right along the upper part of the LV outflow and along the septum. That really made it very difficult for them to, they were quite concerned about the subaortic area. And when they're significant, they may be really problematic long-term. In this baby, he ended up ultimately having an arterial switch, but we're still watching to see what happens with the mitral valve tissue and how much outflow obstruction there's going to be in time. So really depending on how big the pulmonary valve is and whether it could still be potentially amenable to an arterial switch would matter. And then you've got the straddles. The straddles are tough, and really you need to it's best to assess, I think, by 3D, but we start with our 2D, and this is just a classic straddling valve in a transposition, or a transposition-like door view. You can also see them in, and you kind of think about them in the same way. Oops, I'm going to go back, see if it'll take me back. There we go, and let it play. So really making sure that you know that the mitral valve is not. So I have seen one case in which the surgeon went to do an arterial switch, and it was only realized in the OR that there was a straddling mitral valve, and he bailed out after doing the switch with PA band and left the VSD and left the valve and had to come back for another day. But you don't want to miss that. And you want to make sure that you've really assessed for straddling valves. So this is a mitral valve that you can clearly see as you sweep up attachments on the right ventricular outflow side here. All right. So here we go. I love the on-pause view. This is a little bit more like a double outlet, only in that where the ventricular septum reconstitutes is different from where you've got your a little bit of anterior malalignment of coronal septum. There wasn't a lot of aortic outflow obstruction, but the bigger concern was just what this mitral valve was doing. So there was sort of rotated papillary muscles, and there was a cleft. So mitral valve straddling is always associated with a cleft, and you've got the two papillary muscles here and here, attachments here along in the VSD itself, which was a huge anterior muscular VSD, and then attachments even over to the coronal septum. So the question is that something that you can repair or not? And in this patient, thus far, it has not been felt to be so easily corrected. It was involving too much of the mitral valve. This is the same case, and you're seeing the sort of appearance. So normally the mitral valve should be entering towards the LV apex or even the free wall. And when you see it opening like this, and especially if you see any diastolic flow that crosses the septum, be very suspicious about some form of straddle. And you can see the pulmonary valve itself in this patient was actually quite good size. Both pulmonary and aortic valves were quite comparable in size, but there's a mass of tissue under that valve that's going to be problematic if you can't resect it or you can't, the VSD is not big enough and you're trying to do an arterial switch. So a lot of turbulence, but I'm going to just stop it. Like I said, this is the only problem with not doing your own slides is you don't really have any control of what you get. And my colleagues were really, really busy giving me slides. So it's hard. This is LA. This is actually through the mitral valve. into the RV. So when you see diastolic flow going through the AV valve into the other ventricle, that's a straddle no matter what. I mean, just about 100% of the time. And you can see there's turbulent flow. In fact, this baby had too much pulmonary blood flow as a transposition, made sure that the atrial septum was fine, and then ended up getting a band to buy some time. This is another one. So, and ultimately, there were discussions about single ventricle palliation, but they were going to re-look a little bit later to see if it was something that could be repaired. So this is another one that I thought was a really bad straddle. Certainly looked like a really bad straddle, and you can see tissue crossing the ventricular septum, and here's your apex or your the ventricular, the crest of the ventricular septum here, and then the LV wasn't looking like it opened up very much on this long axis image, but in the short axis it looked better. And there was a huge ventricular septal defect, and you're really not seeing the pulmonary outflow very well. Again, the 3D gives you some sense that there's tissue on the other side for sure, but then Jeffrey Smallhorn played around with it a bit and was able to get a little more sense of this. So here's the valve annulus, and there's tissue that's going this way and tissue that's going into the LV. But in fact, what he found was mostly just attachments of a big papillary muscle on the right ventricular side of the ventricular septum here, and that the rest of the hole was quite huge. And he was able to guide our surgeons, see it here, so the hole was quite big. And so the most of the hole, in fact, was unobstructed. And as he was able to guide the surgeons to go ahead and do baffling, which this patient actually tolerated quite well. The subpulmonary was quite obstructed. And so it really required a baffling in this context, but it was successful. So there are various etiologies of LV outflow obstruction and transposition, and some of which are more challenging than others when attempting repair. Certainly, meticulous imaging is important to better define the mechanisms of obstruction. And 3D echo, as mentioned, we've used it quite a bit, and the models, the 3D models, have definitely become standard of care in our practice. Now, I'm just going to move on to something that is a little more fun. I'm not going to tell you too much other than giving you the left-right orientation. So I had this mom sent to me. She was about 34 weeks. And I had it's always one of those things. And one of the things that we do, most of the stuff is stuff that we see all the time. So it's, you sort it out, and then you have to sit and talk with mom and dad or the couple and make sure that they're comfortable with kind of what's discussed. But this was sort of an interesting case, just in the context of some of the discussions that we've had. So you can see that the stomach is on the left and most of the liver's on the right. There's a descending, the IVC, so we're going to say that this probably is situs solidus, and then it's kind of blurry, right? So, but as a start, your IVC is on the right, descending to the left, you've got your stomach here on the left, and the heart is to the left. So I've got a little bit more images of the four-chamber view. That is really jerky, I'm not sure why. And I heard some, what do you think? Yeah, so that's the first thing you'd think about. So this is the left, this is the right. We said that the IVC came into the right side atrium. Sorry, it's so jerky. I don't know why. Pulmonary veins are here. And definitely this ventricle has moderator band, right? And they always look kind of foreshortened. They're not so foreshortened. They look even worse in the first trimester, but you can see that offset of the AV valve, and the one that's lower in the septum is actually the tricuspid valve. So for sure, that's the first thing you're thinking. This is CCTGA. But then we swept. Sorry, it's being really jerky. Not me, the image. Sorry, this is very strange. Very weird looking 3-vessel view, I have to say. And then poor Shijune's not here. So my apologies. This is still the same ventricle, and we're sweeping up. I don't know why it's doing that. But this ventricle, which is on the left ventricular side and looks like a right ventricle, is giving rise to this vessel. And then the ventricle on this side is giving rise to the other. That's just a short axis. So we'll have some more images, and I have some postnatal images. So this is this is the right-sided ventricle. I don't know why it's so jerky. You don't usually have that trouble. And it gives rise to this vessel. And then one more image. Any thoughts? Sorry, it's so jerky. I don't know why the system's doing that, but not normally like that. Any thoughts? So you would call that AV discordance and BA concordance. Yeah, that's the amazing thing. So we have AV discordance and BA concordance. So there's L ventricular looping with inverted great vessels. So they're coming off their correct ventricle. And this is number 2 that we've seen. The last one we saw is now a 1-month-old that we're dealing with. So what's the pathophysiology? What sort of things are you going to say you're likely to need to do? What sort of things are you going to tell your newborn specialty team? Okay? Yeah, so this one's going to need an atrial switch. What else might you want to think about? Think about the pathophysiology. What else do you want to think? What do you think this baby's going to be like at birth? Exactly. So that's the first thing that we talked about is this baby could be quite blue. So you need to make sure the morphology of that the atrial septal defect is fine. And this was not the case. This baby, in fact. So we were worried about the atrial septum, not worried enough to yet deliver in our surgical center. But in fact, you have to think about cyanosis because you need to be able to mix. In fact, that is the treatment as a newborn with this diagnosis, right? So this baby delivered at term was quite cyanotic, in fact, and ended up being rushed over to our hospital and getting an emergent balloon atrial septostomy, which is what you would want to do anyways, just not have to do it emergently. And in fact, the baby that we have right now wasn't so blue, but needed a balloon atrial septostomy to be able to stabilize, right? And this is her anatomy. So IVC to right atrium, an intact IVC on the right. So we just confirmed a bit of the anatomy. The atrial septal defect. This is the baby actually prior to getting a good septostomy, but the SVC is coming into the right atrium. So situs solidus, the pulmonary veins coming back to the left atrium. And we're just starting to get some sweeps in the outflows. But we'll see some more. So LA with pulmonary veins to RV with a moderate advantage, you can see here, and a classic looking tricuspid valve. The one that we have right now has an ebstenoid tricuspid valve, which adds a little wrench to the whole thing as well. And here's your LV receiving blood from the right atrium and the systemic veins. So that was all pretty normal, and the tricuspid valve looked okay. And this is what you would normally see in an L transposition, but of course that's not what this baby has. So the RA goes to the LV, goes to the aorta. And, but that looked pretty unobstructed. That looked pretty nice. There was a little ventricular-septal defect, which we were hopeful would last. Here's your pulmonary outflow from the left-sided ventricle, which is the right ventricle. So LA to RV to pulmonary artery. Like this. The baby still had a duct. And then some of the images, other images. So the hard part was that this baby's had a paramembrous VSD, and as a newborn, it didn't look too small. But so we said, we're going to let this baby go. We're going to try to get this baby off for a few months and then bring him back 6, 7, 8 months, whatever, to do an atrial switch as far as you could go. And unfortunately, within a few weeks, the baby's ventricular septal defect was becoming restrictive. And then we were starting to get worried, and the baby was starting to get a bit blue. So we bought a little bit more time. This is a little bit more of the images. So here's your left-sided right ventricle, right-sided left ventricle, something that we are more used to seeing, and then the great vessel relationship. And in fact, this was the best one because it's really an inverted relationship with the great vessels with the aorta here and the pulmonary artery wrapping around to the left, or to the right, sorry, wrapping around to the right, and the SVC is here. So what should we do? What should be done? And we consider this as L ventricular looping and inverted great vessels. Did the balloon atrial septostomy. We were a little bit worried that the VSD was restrictive, but we sat it out for a little bit. So we tried to get a few months and perform an atrial switch. And in fact, this little peanut came back. We were a bit worried about the VSD becoming restrictive because you want your we were a little bit worried about the VSD becoming restrictive, but ultimately this baby had an atrial switch, which we're showing here. That was successful at 3 months, and she's still doing quite well. So that's flow from the IVC. You're seeing red flow coming across to the left ventricle on the side from the pulmonary veins. And I think that was it. Anyways, so thank you very much for your attention, and my apologies for not having a more organized talk. First time in 30 years.
Okay, so for our final talk of this afternoon, and thank you to everybody for sticking with us for this great session, I'd like to introduce Dr. Malik Yaman from Cleveland Clinic, who will speak about the role of advanced imaging, virtual 3D modeling, and 3D printing to guide complex septation.
Thank you, Fran. And again, good to be here. This was a great, I think, session. And being the opportunistic guy that I usually am, I conveniently positioned myself at the end of this so I can sort of build on all the knowledge that was offered by the various speakers and hopefully try to wrap it all up in a meaningful conclusion. One disclaimer that I have to give is even though there's 3D in my title, there's actually less 3D than the earlier talk that Dr. Ehrenberg gave. So I'm a little bit of a, kind of a little bit shy about that at the moment. But if you feel like you need some of your money back, we can talk to the organizers and see if, but hopefully you'll find it somewhat useful. All right. All right, so I think that the way I think about it is what is an unseptatable heart? So simplistically, it's any heart that cannot be divided such as to have two pumps in series. It is very much a moving target because, as we learn more, as we use more and more multi-imaging modalities, as there's more data guiding us as to which hearts are septatable or not, more surgical innovation, et cetera, I think this has kind of become a more moving target, and the boundaries between septatable and unseptatable have become a little bit more blurry, and we're sort of redefining things as we go. It is very much a team approach, so these cases, whenever we face them, they require not one, not two, not three, but more and more discussions and to really try to figure out what the best approach should be. And it is very center specific. So you really have, every person has to, within each center, try to push the boundaries as much as possible, but also know your team and your center. And ultimately, you have to decide to do what is the best thing within your own team and within your own center, because that could be very different. So defaulting into a univentricular pathway, as you've seen, in many of those talks, there are obviously many anatomic barriers to septation. And some of these include complexity of venous drainage, as we saw from the heterotaxy talk. There's AV valve considerations that have to do with commitment, papillary muscle number and configuration. Obviously, straddling is a big one. Size also matters, so ventricular hypoplasia, remoteness of the VSD from the aorta, as we saw from the double outlet right ventricle talk. But I think there's also conceptual barriers to septation, and those are also important, and those are also hard to break. And some of those conceptual barriers include the perceived need to place LV in systemic position. We don't have to always place the LV in systemic position. Obviously, that would be the most desirable route, but if it's not doable, then that should not prohibit us from thinking about other means of septation. And that placing LV in the systemic position may be sometimes prohibited by either complex venous anatomy, routability of the LV to the aorta, or sort of borderline size of the LV. I also think that many times we underutilize the 1.5 ventricle circulation. There is obviously controversy whether that can help in the long term and give advantages over the Fontan circulation because of the murky data about the sort of the benefits of 1.5 ventricle circulation. But we do think that 1.5 ventricle circulation in well-selected patients will have long-term advantages because you do have two pumps, you do have the ability to increase your cardiac output with exercise, and as some of the cases that Dr. Nejm showed yesterday, when you go from the Fontan to 1.5 ventricle circulation, you decrease your central venous pressure in your right atrium significantly, and it is that right atrial hypertension, or lower body venous hypertension. This is what leads to a lot of the complications of the Fontan, including PLE and the liver problems that we see. So in well-selected patients, 1.5 ventricle circulation may mitigate some of the effects of the Fontan circulation. Also, the long-standing dogma, as Hani alluded to yesterday, that if you have two ventricles, and you put them into a Fontan circulation, those are going to do better than if you have a signal ventricle in a Fontan circulation. And clearly that's been demonstrated not to be the case. Also, there's the barrier that complex procedures may have more complicated immediate post-op course, and that they may ultimately need more intervention. So if you were to put a ventricular to pulmonary artery conduit, you're going to need more conduit revisions as opposed to saying, well, we're just going to do the Fontan at 3 years of age, and that's going to be good, and we're less need for conduit replacements and so forth. So those are some of the conceptual barriers to septation. So whenever we faced with that big question to septate or not septate, we obviously approach this just like with any question in congenital heart disease. We always take a segmental approach. So we look at all the cardiac segments, starting from the veins all the way to the great arteries. We use multi-imaging. Obviously, we all know that by now, but the new kid on the block is the 3D printing. And we do heavily rely on 3D printing at our program. It's really a tedious process, and thanks to a wonderful engineering team that we collaborate with, who does a lot of the groundwork with segmentation, 3D virtual modeling, and ultimately printing these hearts. I could watch this all day. It's very soothing. All right, so and we've had quite a bit of experience. We almost have printed 50 hearts now since 2016. They're all lined up in Dr. Najm's office, and we have found them quite useful for our surgical planning. Now, I have to say that sometimes, those, from my perspective as an imager and sort of as helping with the decision making, I feel like some of those 3D models are more like the icing on the cake in terms of knowing what the right answer is, but sometimes they truly help, and they can change our decision making in several ways. So, but whenever you approach this now with this new thought process, the paradigm is now changing, because the same exact patient, if you go down a Fontan pathway, and by the time you get to finish the Fontan, that patient has a very simple anatomy. Like, you almost don't care about the intracardiac anatomy anymore when you're doing the Fontan. But on the other hand, if you're thinking that you're actually going to be doing septation, all of a sudden that same patient has become all of a sudden much more complex. So that is where the changing paradigm is. And if your ultimate goal is the Fontan circulation, there's a slew of information and important morphologic and functional factors that you have to study very carefully. We used to call them the 10 commandments of the Fontan. So, but if your ultimate goal is either 1.5 or 2 ventricle circulation, so you really then care about all the above issues, plus a whole slew of more issues. So if your goal is to achieve biventricular repair, you want to look at each ventricular mass. What is its function, the volumes, the commitment of the AV valve, the papillary muscles, any issues that you're going to face with atrial partitioning, the VA relationship, straddling, is it surgically manageable or not, etc. And then we still have to decide, are we going to place the right ventricle or left ventricle in the systemic position? And that decision in itself also will invoke several factors. Which one has the combination of better volume and function? Which one can be challenging from a straddling standpoint? What is the VA relationship? And how, for each choice of either sub-aortic RV or LV, how are you going to approach that from an atrial partitioning standpoint? So really, you have to look at the patient's anatomy in totality. And for each patient, there are conceptually multiple options possible. And after extensive review, we have to decide what is the best for each patient. Sometimes the decision is no septation, and we have to do single ventricle palliation. And you really shouldn't let your ego or your desire to innovate get in the way of decision making. If it's in the patient's best interest to not septate, that should be the right decision. Or it could be 1.5 ventricle circulation. If it could be 2 ventricle circulation, and with each of these options, you could please place the left ventricle or the right ventricle in the systemic position. And whether you do LV or RV as systemic ventricle, each will entail a very different atrial septation and management of the outflow tracts. And as Dr. Najm alluded to yesterday, this complex septation can be either a forward approach in cyanotic and unseptated patient with some form of pulsatile pulmonary blood flow or Glenn. And we do this in order to obviously mitigate the effects of cyanosis and provide them with 2 pumps. or it could be a backward approach from a failing Fontan circulation, going back to a 1.5 or 2 ventricle circulation to treat the failing Fontan physiology. This is the paper that was mentioned yesterday, and I'm obviously not going to go through it, but this is the paper that kind of broke the dogma that 2 ventricles, they're certainly not better than 1 ventricle in the Fontan circulation. So this is from Australia and New Zealand. They looked at quite a large number of patients comparing 2 ventricle Fontans versus 1 ventricle Fontan, and they defined 2 ventricle Fontan as all of those who basically have 2 good ventricles, but they had a Fontan palliation for reasons other than ventricular size. And they include things like double outlet, AV septal defects, and CCTGA. And what they really found when they looked at a composite endpoint encompassing death, heart transplantation, Fontan takedown conversion, PLB, PLE, plastic bronchitis, or heart failure, that composite endpoint did not differ between Fontan circulation that had 2 ventricles versus 1 ventricle. And it's based on this data that the team at the Cleveland Clinic has really tried to push forward with septation. This is the early experience that was published a few years ago. So we really have many more patients now that hopefully will publish. But we looked at the early experience with septating 5 patients previously deemed unseptatable, in this case, placing the left ventricle in subpulmonary position and therefore achieving what we call CCTGA physiology. And, the anatomy is shown here. We definitely use 3D modeling and printing for all of them. And you could see that achieving that circulation involves a complex surgical operation that involves septating the AV valve, repair of anomalous pulmonary venous drainage, atrial conversion in all patients, rerouting of extracardiac systemic venous connection, as I'll demonstrate shortly, and placing a conduit. On short-term follow-up, these patients did well. They were alive, and the recruitment of their LV into the circulation improved functional status and significantly increased, systemic oxygen saturation. So some encouraging early results. So for the way I see it is the role of advanced imaging and 3D printing has to do with the obvious ability to assess ventricular volumes and function, do 3D spatial determinations that allow us to examine septatability from A to Z. We look at specific issues in atrial septation. A big one is routability of the VSD to the aorta. I'm not sure, is routability, is that a correct English word? I don't know, but I don't even, septatability may not be a correct English word. And then positioning conduits, relationship to the sternum, etc. So I'll just show some case examples that I felt, where imaging helped with, that I learned something from them, and just to kind of show you some of the issues involved with these patients. This one was also presented yesterday. He was a 31-year-old male with native, cyanotic balanced congenital heart disease, balanced between parentheses. He had right isomerism, a complete balanced AV canal, so had 2 good-sized ventricles with D-loop ventricles. Good AV valve function was good, ventricular function was good, but he had double outlet right ventricle with demelt post-great arteries, some degree of pulmonary valve stenosis that have sort of kept him to some degree balanced. But what kind of stood in the way of septation in this patient over the years is that he had some complex venous anatomy. So he had bilateral superior vena cava and supracardiac non-obstructed total veins to his left SVC. He also had the left IVC, but in addition had a separate right hepatic venous drainage. Now, even though he was called as balanced, but he actually stroked out at some point, and he was polycythemic, and his stats were, kind of 80%, but despite that, he had polycythemia. So this is kind of just some selections from his CT that kind of how we began to think about him. So this is just sort of a modified axial view that showed the ventricular looping, and it shows you that the ventricular volumes were reasonably good and they were balanced. So this is RV, his LV. This is a short axis view that showed the septum smack in the middle, again, kind of a balanced ventricular, balanced ventricles. And then a more basilar cut to show in planimetry, or the orifice of the AV valve, and how the AV valve orifice as well suggested that it's well or equally committed to both ventricles. And then when you take a closer look at the location of the inlet VSD and then the aorta, it really seemed that it would be quite difficult to route this inlet VSD to the aortic valve. So that started to kind of play in some role in the discussion. Then, of course, as we mentioned, there's a right hepatic vein and a left IVC. And then we had bilateral SVCs, and we always, whenever we see these bilateral SVCs, what Dr. Nejm has sort of pushed forward is to try to create a surgical neo-innominate vein. So to try to take one of the SVCs to the other one, creating a surgical innominate vein. So we always try to measure the lengths of these SVC and see which one is translocatable to the other. In this case, we felt that this one had enough length to it that you could create a neo-innominate vein. And then, of course, we shouldn't forget about the total anomalous pulmonary venous return. So this is the confluence behind the middle of the atrial mass. And what happened to it? It ultimately went through this vertical vein all the way up to his left SVC. So as we were discussing this case, we said, well, there's adequate biventricular size and systolic function with the right ventricle on the right and the left on the left. So there was a question of routability of the LV to the aortic valve through large inlet VSD with no outlet component whatsoever. So that really seemed to be based on the tomographic imaging and the 3D printing. We felt that it was going to be quite difficult to route the LV to the aorta versus keeping the RV asystemic, and there was every evidence that the RV had good function. And the pulmonary valve in this case was not usable for an arterial switch. The pulmonary venous confluence was behind the middle of the atrial mass, so you could really kind of connect that to either atrium if you wanted. The left IVC and the separate and remote right hepatic venous to the right, and then you had the bilateral SVCs with the right SVC having enough length to be translocated to the LSVC. So what did we do? We did complete AV septation, creating CCTGA physiology. So we kind of septated the atrial component and the ventricular component. We translocated the right SVC to the left SVC behind the ascending aorta. In this case, the aorta was very anterior, so we kind of created a neo-innominate retroaortic vein. We also routed the hepatic veins to the left atrium via hemi-mustard, and we kept the IVC on the left side, which was convenient. And then we anastomosed the pulmonary veins into the right-sided atrium, so we connected it to this atrium. And then did an LV to PA conduit with a 25 millimeter BioCore valve in the middle. And this way, this patient basically achieved CCTGA physiology and has done well, and he's no longer cyanotic. Another case example is actually a patient of mine that I had met in utero, and she has right atrial isomerism, midline liver, dextrocardia, L-loop ventricles, unbalanced RV dominant AV canal, LTGA with pulmonary atresia, confluent pulmonary arteries supplied by left PDA from the innominate artery, confluent pulmonary veins connecting to the middle of the common atrium. Postnatally, she had proximal narrowing of the branch pulmonary arteries, which we presume to be due to abnormal ductal tissue. So rather than stenting, we decided to do a conduit. We discussed whether to do a BT shunt versus an RV to PA conduit, and the decision ultimately was to put an RV to PA conduit. And she did well, but now she's 11 months, and she kind of outgrew the conduit, and we brought her in to see what the next steps should be. So just quick highlights from her MRI. We did an MRI at the time. Also, you could see now the venous issues. So you could see that she had a left SVC, a right IVC, and pulmonary veins, which are sort of smack in the middle. And then this is just from the cine images showing clearly that she has L-loop ventricles, the right ventricle on the left. She has dextrocardia. She has, unbalance. So you could kind of look here at the plane of the AV valve and see that it's probably 30% committed to the right-sided morphologic LV. And if you look closely, as is common in these right atrial isomerism, there was only one papillary muscle on the morphologic LV side. So clearly, lots of factors in terms of the degree of LV hypoplasia, the AV valve commitment, the presence of one papillary muscle. So we thought, well, really, the two options, well, let's look at some numbers. So the index RV volume was 85 with good ejection fraction. The index LV volume was 25 cc per meter squared. And obviously, we looked at z-scores and we looked at the normal value. So if you say the normal value for a newborn is about 12, or for an 11-month-old was 12 to 18 cc's, she was about 8 cc's. So she was sort of 3/4 of what the lower limit of normal LV would be. The AV valve commitment was, again, 30% to the morphologic LV, and she had one left-sided papillary muscle. And the IVC was right-sided with a right-sided posterior LV. So I think that the two only valid choices in this case were pretty obvious, either single ventricle palliation, or how about we try to use 1.5 ventricle palliation with the LV as subpulmonary ventricle. And this is what we did. So we, as you remember, so she had the left SVC, so we created a left glen. We did the atrial septation so that the right IVC drain continued to be to the right atrium and the pulmonary veins to the left atrium. We closed the VSD. We placed an LV to PA conduit, which had, one, the advantage of not being under the sternum, and two, since the left ventricle was on the right and the glen was on the left, it kind of put it at a distance from the glen, which was nice. She's actually, I follow her. She's 5 years old. She gives me high five, and she's not, she has some RV dysfunction and AV valve regurgitation, but she's doing quite well. So some considerations in atrial septation, as you know, like depending on the exact topography of the veins, you may either do actual baffles or just kind of recreate the atrial septation. And so this is where the details are important. So we need to know the number and size of the SVCs. Is there a nominate vein? Does one of the SVCs drain to a coronary sinus? Is it roofed? Where is it? How is it related to the pulmonary veins? And where are the IVC and any separate hepatic venous drainage? So this is a case that all we need to do is kind of look at the axial black blood images from an MRI. This is, I'll not show you all the details. This is just a dextrocardic heart whereby the decision was made to make the right-sided ventricle the systemic ventricle. In other words, when we're looking at this, we're deciding, okay, how do we make the pulmonary veins drain towards the right and the systemic veins drain towards the left? So we start at the top, we have bilateral SVCs, and as we go down, we can see, let's focus on the left SVC mostly, and we see that the left SVC drains to a roofed coronary sinus. The pulmonary veins drain to the middle of the atrium, and there was a very unusual atrial septal configuration that kind of had different directions here, and you could see that the pulmonary veins, as a result of this weird atrial septation, drain to the left side of the atrium with some restriction between the coronary sinus and the atrial septum. So the way to tackle this, if we want to make the pulmonary veins drain to the right side and the systemic veins to the left side, is what needed to be done was taking down this part of the atrial septum, reconstructing this part of the atrial septum such that it kind of connects this way. Then what do you do with the coronary sinus? You unroof it partially so that the coronary sinus drains to the left-sided atrium, and the pulmonary veins now drain to the right-sided atrium. And then what did we do with the SVCs? We translocated the right SVC because we want everything to drain, systemic veins to drain to the left side. In this case, we created a right SVC to a left SVC, or right neo-innominate vein. And then we ultimately did a hemimuster to connect the right IVC to the left-sided atrium. So, I mean, I think surgery seems to be pretty easy when I look at it here on my MRIs. I don't know what all the hype is. I mean, I feel like I could be a heart surgeon. So this is an example of, something I learned from a recent case. This is also a fatal case of mine, which was a crisscross heart. And I'm not going to show all the fascinating imaging on this patient, but I'll just show you some highlights from the CT scan, and I'll show you what kind of took me by surprise in this case. So this was a case of abdominal atrial cytosolitis, but you could see here that the right-sided atrium drained through the mitral valve to this inferiorly positioned left ventricle, and then the pulmonary veins drained through the tricuspid valve in this fashion to the more superior morphologic right ventricle, and that's why they are crisscross AV connections. And you could also see here that there is, the two great vessels are coming off the right ventricle, so it's a double outlet right ventricle. And then if we slice it this way and look at it sort of in a modified coronal view, you'll see that this is the inferior left ventricle, this is the superior right ventricle, this is the plane of the ventricular septum, this is the VSD, this is the pulmonary valve, so it's a subpulmonary VSD. So as you can see, this is AV discordance, but functionally, because it's a subpulmonary VSD, it is VA discordant. So physiologically, this baby had congenitally corrected transposition. And since he had this very weird aneurysmal tricuspid tissue resulting in subpulmonary obstruction, he actually remains to this age. He's about a year and a few months, somewhat balanced. His stats are in the lower 90s. He hasn't had heart failure. And so we're still watching him very carefully. Now, so what we were really focusing on is it was very hard with all the imaging to really tell whether this pulmonary valve is going to be usable or not usable for an arterial switch. And that was took a lot of our discussion, because what we were thinking of is if we can safely resect this aneurysmal tricuspid tissue while preserving the tricuspid valve function, and build a VSD here and do an arterial switch, do a double switch at that point, then that would be the way to tackle this surgically. And a lot of these discussions focused on the routability, the resectability of this tissue, the anatomy of the pulmonary valve. And we certainly 3D printed this heart and looked at it. We looked at the coronary morphology. Certainly the path of the VSD to the aorta was not suitable for a Rastelli. That was clear from the get-go. Now, I'll tell you that after all these discussions and after looking at these prints, what I least expected in this case, what I learned from this case, is that what was going to be the limitation for an anatomic repair was the atrial baffles. And that's kind of what I learned from this case. So this was the $1 million picture when we looked at it and when we held the models. This is the systemic veins. This is the pulmonary venous atrium with the weird pulmonary veins in the back. But this delineates the tricuspid valve location. This delineates the mitral valve location. And after looking at this with Dr. Najim for hours, we figured that there was no meaningful way to create intraatrial baffles and partition these atria. Not even a hemi-mustard would be feasible. So this was actually the very first case where an atrial septation was prohibitive to the whole thing, and that was a good learning experience for me. So we figured that really the only way we're going to tackle this is with a physiological repair. So resecting these VSD to pulmonary valve and creating a physiologic type repair. And we're still we're going to probably do that in the next few months. Routability of the VSD, we saw some of the elegant slides from my colleague earlier, but this was one of the cases I think that was shown. This was a 4-month-old transferred to us from another institution with double outlet right ventricle, DMAL post-great arteries, and large inlet VSD, somewhat remote. They called them a Taussig Bing, but we really didn't think this was a Taussig Bing because it shows you that the relationship of the great vessels does not define the physiology. It's really the streaming of the blood through the VSD and the location of the VSD. They even did a balloon atrial septostomy when before he got to us, and the stats of this baby were in the high 90s. So certainly not a Taussig Bing physiology. Had multi-level pulmonic stenosis, etc. So we were considering him for surgical repair. When I look at the surface topography, this is finally a double outlet right ventricle that everybody in this room would call double outlet right ventricle, because I am tired of the 50-50. Is this Dorv? Is this not Dorv? When I get a Dorv that everybody calls a Dorv, I'm just happy. Anyway, so this is a Dorv that everybody will call a Dorv, as you can clearly tell from the surface topography. Now, this is the inlet VSD, which rendered the AV valves at the same level, but it's not an AV canal, as you'll see from other pictures. You could see here the VSD, and as we look upward towards the aortic valve, we start to see maybe some promise that this VSD, despite being inlet VSD, is routable towards the aortic valve and may be suitable for a Rastelli. And you could see how, physiologically, this is not a Taussig Bing. Yes, the aorta is anterior and rightward, but the streaming of the LV it really positions this VSD closer to the aortic valve than the pulmonary valve. And this is another look from the RV, sort of a modified coronal view, also showing that the VSD is probably closer being a subaortic than a subpulmonary, kind of in the DMAL post-great arteries. This is more of a subaortic VSD. The CT helped us show the morphology of the AV valve, so it's certainly not a canal because this looks like a mitral valve, this looks like a tricuspid valve. But the deal breaker here that I learned from this case is that what was prohibitive towards a Rastelli is this particular distance. We measured basically the distance between the tricuspid valve and the pulmonary valve and compared it to the aortic annulus. So that distance was about 8 millimeters versus an aortic annulus of 12 millimeters. And this is the part you just cannot enlarge. You know, if the tricuspid valve, in this case, and the pulmonary valve are too close to one another, that is a setup for failure of the Rastelli and later on LVOT obstruction. And this is a slide from Dr. Nejm that he shared with me. You know, for these D-mal post-great arteries, what you really desire to have is no pulmonary valve in the way. This is obviously a prohibitive case, but our case was probably similar to this one, where the location of the pulmonary valve was prohibitive towards a Rastelli. So this patient ended up with a physiologic type repair rather than an anatomic repair because of this feature, which I learned about. Sometimes it's pretty obvious. This is another case who had CCTGA with pulmonary atresia and had a prior BT shunt. And I felt like in this case, it was pretty obvious that despite this being an inlet VST, a Rastelli was going to be feasible. And I feel like in some of these cases, you know, the 3D printing and modeling is like the icing on the cake. We kind of feel more warm and fuzzy about routing the VST to the aorta. But as Dr. Ehrenberg showed earlier, it also helps us learn about how much of that potential volume from the RV is lost towards the baffle. So this is a case where ultimately we deemed it routable, and he underwent successful Rastelli sending. This is a case where I think that shows the powerful role of 3D modeling, because this is a case who had double outlet right ventricle with PS and VST, and I'll try to wrap up here because I think I took a little bit too long. He had a failing Fontan, had bidirectional Glenn, a non-fenestrated Fontan, a pacemaker, and he had previously had occlusion of forward flow across his main pulmonary artery. And he came to us with failing Fontan and PLE at 11 years of age. So he had two pretty good ventricles, but despite that had a Fontan. And this was a learning case for me, because when we looked by both TEE and CT, just the raw data, every cardiologist in the room said this is a remote VST. The pathway is too long. We cannot route it to the aorta. And it was only after 3D printing, when we looked at the model and held it in our hand, that we figured, the VST, first of all, can be enlarged because the patient already had heart block, and we can resect a lot of the muscle bundles from the RV free wall in order to route the VST to the aorta. So this indeed is what happened. The patient underwent 1.5 ventricle repair, as you can see here, but ended up with a sub-aortic morphologic left ventricle, and the LVOT was wide open, as you could see from this angiogram. So this, to me, was a good demonstration of how 3D printing is redefining the whole concept of remote VST and how septation can be used as a salvage strategy in failing Fontan circulation. I think I should probably skip this case. Don't you think, Fran? Yeah, I mean, this was just a case that I wanted to show you that sometimes the answer is no septation, even though our desire to give everybody 2 pumping chambers is a very strong desire. But at the end of the day, after careful consideration, sometimes we say the best thing is to do a single ventricle palliation. So I wanted to show this case as an example of why that should be, and how 3D printing can also help us not only in offering septation, but also to say single ventricle is what needs to be done in this case. So, all right, so this is just a discussion of this case. So in summary, we have to pay attention to all aspects of anatomy and function. We used all imaging modality, including advanced imaging and 3D printing. We explore all the options. The conceptual work with planning and discussion really constitutes half the work, and it's a teamwork approach. Pushing these ventricles to a 1.5 or 2 ventricle circulations is further justified by the long-term outcome of single ventricle palliation, but we obviously need a lot more data to prove that septation improves long-term outcomes. Thank you, guys.
I know the hour is late. If we have any questions, we're happy to field them, and otherwise we'll get everybody on their way.
I can only make one comment. Looking at, all the, the all imaging presentation that you guys have made, what I can see is making a diagnosis and getting to a conclusion as to what is the best surgery for the patient is also an ongoing and evolving work. So when we are counseling the families, even in the prenatal period, I think we have to, come off this thing that we have to give them a definitive answer. We just have to tell them that the situation is complex, the diagnosis is an ongoing process. What ultimately is best for the patient will be decided, but it is going to be a teamwork. It is going to be, a team decision and not one person decisions. Those days are gone when there were surgeons who would just ask their cardiologists what to do, and they will just act like a plumber. And those days are also gone that there were surgeons who would just do whatever they wanted to do and don't listen to their imagers, So I think it's all a teamwork, and we should not feel compelled that we have to tell the parents definitely what needs to be done. We just need to explain to them the severity of the situation and let them go through that process whereby they will feel comfortable that the big team of imagers, the intensivists, the anesthesiologists, and the surgeons are going to make up their mind as to what is best for their child and best for their child in the current available knowledge. We still, know that there are long-term sequelae as well for the treatments that we're offering nowadays, right? Some of them are known, some of them are not known. So we can only offer the families what we know in the current available, in the light of current available knowledge as to what is best for them, what the future has for them. Nobody can predict sometimes. So this is, I think it's an ongoing process as to what the diagnosis is, first of all, what the best procedure for the patient is going to be, and what is going to be the ultimate long-term outcome from this.
Thank you. In my practice, in our practice, what I usually do, I always think about prenatal counseling as giving them all the options. So giving them all the options and guiding them as they go along. And so it's important in our practice to have the fetal cardiologist will be that same fetal cardiologist throughout. And if it's a single ventricle, it will be that patient's doctor. The single ventricle will be the fetal doctor will be the patient's single ventricle doctor. So I think trust starts prenatally. And I've always give them the spectrum of outcomes. You could be like this, you could be a single ventricle, you could be a two ventricle if we're not sure. Or, and when we counsel for single ventricle patients, we counsel from postnatal delivery to Fontan. They need to know what's going to happen. That transplant is not an if, but a when in this decade. I mean, in this current era. But we also say that in the future, we won't know what happens. Fontan research has been like top speed right now. And who knows, we will have solutions like this, taking down the Fontan, making a single RV because the single RV is better than failing Fontan with PLE. And that's actually very compelling. So I think an ongoing dialogue, we always tell them that this will not leave you. After the fetal counseling, this is not going to be it. We will be talking to you and guiding you along the way. And if there are new technologies, then we will let you know. If you read, and right now in the advent of social media and single ventricle family groups, Mended Little Hearts, Sisters by Heart, they have all the options. They have parents who talk to them. If they want to go elsewhere, I have patients who want to see what they have in Boston Children's. And then the advent of they can do telemedicine, I welcome it. And then again, autonomy and I think informed consent, as well as guidance and not leaving them throughout their life until retirement.
I totally agree. So especially for the more complex ones where you really don't know. I mean, some of them, they're hypoplast, where are you going? But I agree, you think about long-term and really give them a good sense of what to expect. I was going to say the other element of fetal circulation versus neonatal and postnatal circulation is the preload and how that can change. And so I'm really cautious with the borderline hearts, because we've had a number, especially either related to restrictive atrial septum, where you would have sworn this kid's LV would be terrible. And I know a very senior cardiologist who had the kitty listed for transplant prenatal because the LV was so small. And that was what we were doing many years ago. And then the baby came out and the left heart was actually okay. So it's being very careful about predicting and giving them, this is what we're going to do. And I was going to mention, Francine, the small left heart elements, the borderline left heart is great. And they are really tough ones. Fortunately, the majority of them, when we've looked at the series, have been able to have two ventricle repairs. But we often will sit tight because remember, when we have these prenatal diagnoses, you're seeing those kids within like minutes or hours of a delivery, and their hearts look different than they will 5 to 7 days out, sitting on prosten and loading. And if they're a postnatal diagnosis, they present to you usually like that with the loading that they're going to have. But as a prenatal, we haven't given them that chance. So we actually will really not make a definitive decision on the kids. We set them on prosten and we say we're going to come back. And we don't do MRIs that early because they, again, have the potential to load up if they're healthy LVs and if the mitral valve's not too bad. So we just give them time to declare the physiology, declare the size of their left heart, and it's been really helpful. And we've had more kids go down the two ventricle track than most people would have predicted on the basis of their first study at an hour, 2, 3 hours after delivery. So another thing to be thinking about. But
yeah, I agree. Those are great points. And I think that our assessment of the babies really has changed because so many of those babies are now born after a prenatal diagnosis. So as you're mentioning, they're like 5 minutes out and we snatch them from the neonatologist and can do our imaging before we've had a chance to allow that left heart to load, as opposed to, like you said, when they were 2 or 3 or 4 days old and we made the diagnosis at that time. I do think, though, that the sort of concept of sometimes doing a Norwood or a hybrid, if that's your institutional's preference, and then allowing them to, sort of return and go down a biventricular strategy. It's not a bad idea either if you feel that the risks of doing a biventricular repair in the neonatal period might be prohibitive and obviously end with a result we don't want.
Yeah, you just have to leave the ASD.
Correct.
Exactly.
Because if you open
Correct.
up the ASD, it all
Then you bring your
redistributes.
bridge.
Absolutely, I agree, and
Which
that's
is what happened with
we
your
did
baby.
in ours. Exactly.
Right, I agree. And I think, we were just talking, Malik and I, when you were presenting, Dr. Ehrenberg, that, all these scores, and we do it too. Fellows will do the scoring every single time there's a borderline left ventricle and surgical conference. And in the end, Malik and I both agree it's just altogram. It's just like all those CHSS, you say univentricle, discriminate, CHS2, all those calculators will say univentricle. And look, again, time and again, there are a lot of these borderline ventricles that will end up being two ventricle, even though those calculators say that they're univentricular. So we take it with a grain of I think a take-home point here is you can do it. Do those calculations, especially for the fellows, that they know that this exists, and but in the end, take it with a grain of salt.
And I agree with everybody's sentiments. Now, I do agree with you, Munir, and everybody that the person doing the field consultation should always have the humility and the ability to say, I can't predict the future, and there's like a lot of different outcomes that are possible. But I do think that as a fetal echocardiographer, even though you're trying to lay out the different potential ways that this could play out, I think you have to inject your experience and stick your neck out. You can't just put different outcomes of equal probability. Otherwise, they're better off flipping a coin. You have to say, well, there's outcome A is the most likely if, certain things, and outcome B is a little bit less likely, but still could happen. Outcome C, and then you tell them how things are going to play out in the newborn period, most likely. And but I do think that you have to use these you have to tell them what you think is the likelihood of things happening, but still tell them that you cannot tell for sure.
Yeah,
And
certainly you have to give them the higher likelihood, but on the other
Absolutely.
hand, and you also give them the confidence by telling
Yeah.
them that whatever situation will be, we can handle it. You just
Absolutely.
Right.
have to give them
We
that
think-
confidence.
We'll always say but I think this is my guess. But
Yeah,
again,
right.
it's a guess. I wish I have a crystal ball.
Yeah.
And then at the end, I would say in our center, these are our outcomes. We are transparent. Here's our outcomes for all comers of hypoplastic left heart. These are interstage mortality, 0, and then our all comers of this tetralogy of Fallot. And then you're welcome to, because especially in our state here in Florida, we have like 10 centers, and they could go wherever they want.
I think your point, though, of it being sort of a team sport is a good one. And I think that that's probably what drove most of us to pediatric cardiology or
I mean, it's like
congenital heart
everywhere,
surgery.
even there was a time that cardiologists on the adult side used to do angioplasty on everybody, And then ultimately they had to settle down on this thing that it has to be a team. It has to be a heart team. Similarly, on the congenital side as well, it has to be a heart team to make an
Absolutely.
ultimate decision.
I like to think it's been a team on the congenital side of things longer than in some of those other areas. So I think maybe that's a good place to stop, and we're all on the same team. We'll continue learning tomorrow. We'll stop to right now. There's a reception and abstract poster presentation at 6 o'clock, and then the dinner at 7 o'clock with the fireside chat without the fire. So thank you, everybody, and thanks to the presenters.